دكتور علي الحربي، ممكن بس تقول له سلام عليكم، بتأكد اني ماني شايف مايك معاك. اي كويس، خلاص اتس اوكي ناو. الحين ظهر المايك، خلاص ما في مشكلة.
بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. I am Mohammed Al-Sineid. I'm the Vice President of Saudi Society of Nephrology and Transplantation. At the beginning, I would like to welcome all of you to the second day of the second Critical Care Nephrology and Hemodialysis Conference. As most of you know, that this conference was supposed to be held last April in Riyadh, but because of COVID-19 pandemic, this conference was postponed and changed to be totally virtual meeting with an exhibition hall. So I would like to encourage everyone to visit this exhibition area at the website of this conference. I hope all of you to enjoy the scientific material of this conference. And fortunately, so far, we have more than 23,000 participants were registered in this meeting. And yesterday, there is more than 6,000 participants attending the first day of this meeting through the Zoom and YouTube. I would like to take this opportunity to thank all the speakers and the panelists for their participation in this conference. Also, I would like to thank all the sponsoring companies for their generous support. It is not a secret to tell you that the preparation for such a conference took a lot of work and time So I would like to thank my colleague in organizing committee, Dr. Khalid Al-Hassan and Dr. Ahmed Mitwalli, and other member in the South Society of Nephrology office, Engineer Nihad and Mr. Sulaiman and Mr. Amir, for their hard work and great effort. It is worth to mention that this conference is accredited by Saudi Commission for Health Specialty for 18 CME hours. And that because the great scientific content in this conference. So without further delay, I would like to ask my colleague, Dr. Saleh Al-Mufadda, to start this session. Dr. Saleh, mic is yours.
Bismillah ar-Rahman ar-Rahim. I'd like again to reiterate our welcome to all our guests all over the world. So I will say good morning, good afternoon, good night, because there is many audience in the different parts of the world. I'm really privileged to present our distinguished speaker, Professor Norbert Lemier. He is a professor with a vast experience in his field, graduated from University of Ghent in 1965, and since that time he's been working hard to develop and in terms of research, in terms of education, in terms of presentation, chairing societies. He had a student all over the world. When I say student, they are now professor in their places. So you can imagine that the magnitude of information and the science he disseminated all over the world. He is certainly somebody we need to benefit from his lecture and type it. He gave the permission to utilize his slides for information or for benefit in the science. I know that with the introduction, they took 5 minutes of his time, but I promise I'll defend him. I'll give him that 5 minutes because we didn't start, but I want him to finish again before a few minutes so we can allow some question from the audience. Please, Professor Lemier, welcome.
Thank you very much. Thank you very much for this very flattering introduction, which was, as usually, all this flattering is a little bit exaggerated, but it's always pleasant to hear that. So for this third lecture, which hopefully will go technically perfect, I promised the organizers that, in contrast with what happened yesterday. So I will focus on a few very important and very frequent and important electrolyte disturbances in the ICU. And for reasons of time, I will focus on acute hyponatremia and then hyperlactatemia. First, focusing on serum sodium abnormalities, you see that there is on both sides of the spectrum of abnormalities in sodium, there is a relation, probably a causal relation between the degree of hyponatremia, where you see that there is an increase in mortality as soon as you get a plasma sodium around 135 and below. But there's also equally an important increase in mortality, both in hospital mortality and ICU mortality, once you exceed the plasma sodium of 145. It's very frequent. It's the most frequent complication in ICU patients, and it is a potentially very dangerous one. Now, just to recapitulate a little bit of physiology, you have to understand that the plasma sodium is a relation between the sodium plus the potassium over the total body water. So whenever you see a hyponatremia, you may think of it as that there is disproportionately too much water in the body for the given sodium present. So just to recapitulate very, very briefly, you see that the plasma sodium is in relation with the total amount of sodium in the body, together with the total amount of potassium in the body. And the reason is simple. Sodium is the most important extracellular electrolyte in the body. potassium, the most important intracellular cation in the body. And that total sum of total quantity of these both electrolytes divided by the total body water. So meaning that there are different combinations of hyponatremia possible. You may have, as you start in the left side upper corner, they may have a decreased amount of total sodium in the body. And that is then called an hypovolemic hyponatremia, because the amount of sodium is in the extracellular fluid. And if there is a shortage of sodium in the extracellular fluid, there is, of course, a hypovolemia. Or, on the other hand, the extracellular fluid can be normal, but still there can be a hyponatremia. Or, as may happen in heart failure, there may be an increase in the extracellular fluid, and so there is hypervolemia, but still there can be hyponatremia. On the other hand, the total body water can be decreased, and this goes often together with the hypovolemic hyponatremia, but still, remember, both hypovolemic hyponatremia, if there is hyponatremia, both the volume are diminished and the sodium capital are diminished, but still there is relatively more water than sodium, explaining the hyponatremia. On the other hand, there can be a normal total body water, and then we call it also hypovolemic hyponatremia, when there is impaired aquaresis, when, for example, the kidney cannot dilute the urine. Or there can be an increased body water, and it can still be euvolemic hyponatremia or hypervolemic hyponatremia. Never forget what happens with the intracellular cation potassium. In the most cases of hypokalemia and depletion of potassium capital, it is due to either poor potassium intake or to losses of potassium in the gastrointestinal fluid or in the kidney. It is mostly associated with a decreased potassium capital, or in euvolemic hyponatremia, there still may be a little bit of loss, renal potassium loss in the urine, but then still it will be associated with euvolemic hyponatremia. We will come back to that because it's important. Sometimes the potassium side in the evaluation of hyponatremia and in the therapy is a little bit forgotten. Just to remind you that water, that there are no pumps, active pumps of water in the body. Everything that shifts is due to changes in osmolality. And in hypertonicity, when there is a relative shortage of water, there's a stimulation by osmoreceptors, both of the thirst and of the release of antidiuretic hormone. And indeed, there is renal water retention until then the osmolality in both the water is normal again. In hypotonicity, the reverse occurs. There is a diminution of thirst. There is a suppression of ADH release. There is less water intake. And due to the suppression of ADH, the kidney is permitted to dilute the urine and to excrete the excess of water. If that would be the simplest, if it would stay there, the physiology of water and salt, it would be quite simple. But unfortunately, the relation and the release of antidiuretic hormone is not only regulated by osmoregulation. There are many non-osmoregulators of water balance, because there are many stimulants of antidiuretic hormone release which have nothing to do with osmolality. And you see there some of them here on the right side of the slide. Nausea, for example. When a patient is very nauseous, there is a non-osmotic release of antidiuretic hormone. Pain, stress is a release of non-osmotic release of antidiuretic hormone. Hypoxia, when there is hypotension, when there is volume receptors can be stimulated, and particularly drugs, many drugs can, independent of the osmolality, directly stimulate the antidiuretic hormone. And it's good to remember in the differential diagnosis of water balance that you always think, why is it now that this patient is retaining water? And don't look only on the osmoregulation, but particularly look at the non-osmotic regulators. For example, postoperative hyponatremia, there is a high level of antidiuretic hormone, which can entirely be explained by the presence of nausea, the expression of pain or of stress, simply due to the surgery that has happened. But then, before I leave that slide, it's important to, in the therapy and in the therapeutic approach of hyponatremia, to remember that if you correct the non-osmotic stimuli of the antidiuretic hormone, if you treat the pain, if you can move away the nausea, if you can correct the blood pressure, then the stimulus for ADH disappears, and then you allow again the urine to be diluted and the kidney to release water. If you at the same moment correct this extra osmolar stimuli for ADH, and you give hypertonic sodium for correcting the hyponatremia, and you act together, you certainly will end up with a hypernatremia, because if you correct the non-osmotic factors spontaneously, the hyponatremia will be corrected because the kidney will be able to release the hypotonic urine. For example, in COVID-19, you see, there are maybe different spectra in one single disease of hyponatremia. There's only a small study, very recently published, but you see, for example, in patients with hyponatremia, with a sodium plasma sodium below 120, admitted in the ICU with COVID-19 infections, 36% of them had hypovolemic hyponatremia, 36% had euvolemic hyponatremia, which is now called the syndrome of inappropriate secretion of ADH. 6% had hypervolemic hyponatremia, and 22% had a very common and often neglected cause of hyponatremia, that is the tea and toast, as the British say. What does it mean? It means that patients can have an intake of osmoles, because if we eat a normal nutrition, you can estimate that we ingest 600 to 800 osmoles per day that have to be excreted again to be in equilibrium through the urine. But if patients have an intake of osmoles due to malnutrition, due to the fact that they are so sick they cannot eat, or due to nursing errors, of course, if we ingest only to 150 milliosmoles, and you can perfectly dilute the urine to 50, you need only 3 liters of water to get rid of this 150 osmoles. But if you intake 5 or 6 liters of fluid and still only 150 milliosmoles of sodium per day, then necessarily, simply because you have not enough osmoles to excrete, you will retain water and develop hyponatremia. It's a very frequent and very often missed cause of hyponatremia, particularly in the ICU. So what are the conditions and the drugs that are associated with acute hyponatremia? And this is defined as an hyponatremia that is generated within 48 hours. As I said, the postoperative phase. Post-resection of prostate, where by endoscopy there is a rinsing of the prostatic field with hypotonic fluids. Polydipsia, don't underestimate in psychiatry. You see often the most pronounced hyponatremia in the psychiatric patient with psychogenic polydipsia, for example, after exercise. Thiazides prescription, I come back to that. Many drugs, just like ecstasy, I don't know how common that is in the kingdom, but we see that from time to time that young girls, mostly dancing the night away during a whole weekend, take ecstasy to be able to do the dancing uninterruptedly. They drink a lot too because they are thirsty, and ecstasy is a potent stimulant of non-osmotic release of ADH, and they arrive in the coma or with epilepsy in the emergency unit. Colonoscopic preparations, intravenous doses of cyclophosphamide, as it's sometimes done in vasculitis treatment, and then, of course, more exceptional, recently started desmopressin. But the most important one, particularly in the ICU, are seen in the postoperative phase. Why is that? That in the postoperative phase, sometimes hyponatremia occurs. This is simply due to a process that is called desalination. And I try to depict pictorially to represent that. Imagine that in a postoperative patient, you infuse 2 liters of isotonic saline. This means 600 millimole that you infuse. Normally, the kidney should be able to, if it can dilute, should put out 2 liters of urine, each with 300 millimole, so that you remain in balance. But due to the postoperative stress, there is non-osmotic release of ADH, and the 600 millimole are excreted in 1 liter of urine with an osmolality of 600, meaning that the second liter that they want to excrete is without osmoles and is pure distilled water. And that water will be retained in the body. And that is one of the explanations why there is so often hypotonic hyponatremia in the postoperative phase and the postoperative patient. Whatever happens when there is a rapid onset of acute hyponatremia, and that is the problem in recognizing it clinically, hyponatremia. The hyponatremia is not characteristic by certain symptoms that you see in the volume status. No, if it is a dramatic and acute hyponatremia, the symptomatology is in the neurological field. There is the small amnesia, and in certain dramatic cases, epilepsy. In a postoperative patient, often please check first your plasma sodium, because it is due to the fact that when there is a rapid onset of hyponatremia, there is a rapid decrease in plasma sodium. And of course, since there is hypotonicity in the extracellular fluid and there is isotonicity in the cells, there is a water shift osmotically from extra to intracellular, and particularly in the brain, the astrocytes and the neuronal cells are very sensitive to that. And there may be cerebral edema, with, even if it is dramatic, leading to an uncal herniation, with epilepsy and even coma, and very often, if it is severe, mortality. And you see that here on an MRI, where you see the normal brain on the left, and you see the MRI with a hyponatremic brain, you barely recognize any structure in the brain due to this edema. How do you correct that? Well, actually, you can make quite complex calculations by trying to establish the amount of milliliters per hour of hypertonic saline. Well, really, the only drug that you can give in urgent and fast developing and severe hyponatremia is administering a hypertonic saline bolus. And please remember only the last part on this slide. You give a 100 ml bolus infusion every 5 to 10 minutes of hypertonic 3% sodium chloride. You repeat that every 30 minutes until the goal is reached. And how is the goal reached? Because by clinical evaluation and observation, and also by repeatedly following the serum sodium and the urine output every 2 to 4 hours during the active correction. And you should never try to correct towards in 6 hours from 120 to 140 millimole of sodium in the plasma. No, it is sufficient to correct by 6 to 8 millimoles sodium per 24 hours to see that the neurological symptoms will disappear, and the rest will spontaneously be corrected later on when the stimulus for ADH will disappear. So remember, 100 ml bolus first, 5 to 10 minutes, look at the patient, correct, take another sodium after 1 hour, watch the neurological situation, eventually give a second or a third bolus of hypertonic sodium chloride until the symptoms disappear and you see that your plasma sodium has increased by 5 to 6 to 8 millimoles per liter. Indeed, the neurological complications and the rate of correction of hyponatremia are closely related. And this graph is very instructive. This is taken from a paper from a journal, in a clinical journal of American Society. And you see, if you look on the x-axis, this is the correction in 24 hours. On the y-axis is the correction in 48 hours. and you see there are no neurological complications, none. In a big cohort of chronically hyponatremic patients with serum sodium below 105 millimole per liter, that you see if you correct over 24 hours and you do not exceed the 12 milli equivalents per 24 hours, and on the other hand, you do not exceed the 18 milli equivalents per 48 hours, you don't see any neurological abnormalities. It is only when you go too fast and you exceed your plasma sodium in 24 hours above 12 milliosmoles, and to be on the safe side, try to aim at 6 to 8 milliosmoles per 24 hours, but 12 is the absolute maximum. And if you correct over 48 hours, 18 milliosmoles over 48 hours is the absolute maximum. The conditions in which overly rapid correction may occur is caused by restoring the electrolyte-free water excretion. As soon as the kidney has get away with this antidiuretic hormone, spontaneously the kidney will dilute the urine and will correct spontaneously the hyponatremia. And this occurs in volume repletion in hypovolemia, when you lower the excessive fluid intake in polydipsia, when you take the nausea away, when you stop eventually antidiuretic drugs, when you stop thiazides, and in very exceptional cases, in glucocorticoid deficiency in Addison's disease, for example, when you treat them with glucocorticoid deficiency, you don't need to give any salt. Simply by replacing the glucocorticoids, your plasma sodium will normalize. What is very important, and I come back to the potassium, dramas have occurred when patients, when young residents were confronted with hypokalemia and hyponatremia, and when they give potassium and sodium at the same moment, they hypercorrect the sodium, and that was certainly what is called osmotic demyelating syndrome. And that's what's happening if you correct too fast. There is an extra pontine and pontine myolysis of cerebrolysis of the cells due to demyelinization of the neurons. And you see that in MRI like this. This was for hyponatremia. Very few things on hyperlactatemia. You see here again, there is a close correlation almost between the lactate levels and mortality in patients in the ICU. Just simply, too simple as possible, reminding you how lactate is produced. Lactate is produced by glycolysis out of glucose, actually down to 2 moles of pyruvate. And the pyruvate can only be metabolized when it can enter the mitochondria through a mediator of acetyl coenzyme A and a lot of quite complex enzymes. And then, of course, it enters the Krebs cycle, it enters the electronic high-energy electron transport, and only in this last phase, to generate ATP, the energy for the cell, it needs oxygen. So the oxygen part is needed only when the pyruvate has entered the Krebs cycle and has then get rid of the pyruvate. Unfortunately, when the electron transport system is interrupted or cannot function because of lack of oxygen, pyruvate is accumulating, and the only way to get out of pyruvate is to go to lactate. And then lactate again can be restored to glucose, and you can end up in an endless circle. I leave you that with this. Don't forget, we produce per day approximately 12 to 1400 millimoles per day of lactic acid in the skin, the erythrocytes, the brain, and mainly, of course, in the muscle. But this is completely neutralized, this big production of lactate, by utilization of the lactic. 90% by the liver, because it is oxidized by pyruvic acid when everything goes normal, or by 20% because the lactate is again restored to glucose due to the gluconeogenesis. And another part, besides the 90% of this oxidation and gluconeogenesis, takes place in the cortex of the kidney, meaning that also CKD, for example, patients have trouble in restoring and correcting the hyperlactatemia. What are the common causes of lactic acidosis? Sepsis, certain drugs like catecholamines, The use of salbutamol, particularly in asthmatic children who use too much puffing of the beta-2 agonist, produces enormous amount of lactate and can even cause asthmatic death. Metformin, a very famous and very common used anti-diabetic drug, anti-HIV drugs. All these drugs can either through intoxication on the electronic transport, on the mitochondria, or by other means produce lactate, metabolic disorders, and certain leukemias and other hematological abnormality, hematological tumors. For metformin, has been a long debate whether metformin is a major cause of lactic acidosis. Forget about it. There is no reason, no evidence that metformin by itself causes lactic acidosis. Under one condition, and that is that if you prescribe it to patients with decreased kidney function, that you stop your metformin and that you adapt the dose from the usual dose of 2.5 grams per day to less than half a gram per day, and that in stage 4 and 5, so below an estimated GFR of 30, actually it is not wise to prescribe metformin to these patients. What are the major conditions favoring the conversion of pyruvate to lactate? I'm not going into detail. Remember, in the intensive care unit, particularly in sepsis, it is the regional hypoperfusion and the dysfunction, the microcirculation, that is important. But most of all, it is the increased circulating catecholamine levels, the neurovegetative and orthosympathetic stimuli of the sepsis that is important for formation of lactate. Why is this? Because if you have a lot of high beta-2 agonism in, for example, by infusion of norepinephrine, but certainly by epinephrine, you stimulate the beta-2 receptor. That leads to an increase in cyclic AMP, and the cyclic AMP is producing glycogenolysis and further also glycolysis, so that you get an overproduction of pyruvate that overwhelms the enzyme capacity and prevent that the pyruvate enters the electronic chain and enters the Krebs cycle, and you get automatically a hyperlactatemia. And this is a beautiful industry illustrated in experimental work, where you see when in hemorrhagic shock in animals, you see in shock no blockers, a dramatic increase in lactate from 0.9 in normal situation to 8.5, and that you can block partially at least if you give a beta blocker agent. A last word about the therapy with sodium bicarbonate, not only from lactic acidosis, but also from ketoacidosis. There's been a lot of discussion, is bicarbonate the ideal therapy for immediately treating any severe metabolic acidemia? There's now been a very nice study published in The Lancet 2 years ago, called Bicar ICU, whereby indeed huge amounts of patients with acidosis, not only lactate, but only ketoacidosis, were treated by bicarbonate, and a control group did not receive bicarbonate. You see, the overall results were absolutely negative. There was absolutely no difference in outcome between the bicarbonate treated group and the control group not receiving bicarbonate, except in three pre-specified outcomes. And these specified outcomes were acute kidney injury. And particularly if you see then in the table below, that only when you have an AKN score of 2-3, meaning a serious AKI, and then you get a serious acidosis with acute kidney injury, then it may be useful to give a dose of sodium bicarbonate, but never try to restore completely your plasma bicarbonate. Why is bicarbonate not always ideal? Well, you may remember that if you give bicarbonate, you produce PCO2, which is of course not good when you have a ventilated patient. You accelerate lactate generation, and this is somewhat surprising to most people when they read that. How can you with bicarbonate accelerate organic acids? You never forget, patients have died because one forget that bicarbonate reduces the ionized calcium. You give, of course, sodium, so you may cause hyponatremia. And at the same moment, you also give an expansion of the extracellular fluid. So
2 minutes to go.
2 minutes, yes. I'm almost finished. So in general, you see that indeed there are many reasons why you have to be careful with bicarbonate therapy. And you see there is indeed a negative feedback control of endogenous acid production. If you give an alkali load, and please look at the right-hand side of this graph, you give an alkali load, so you increase the systemic pH immediately in the cells. The systemic pH will lead to an endogenous acid production, ketoacidosis, lactoacidosis, in order to restore this pH again to the initial level. So there are many reasons why you should be very careful with bicarbonate. And then my last slide, I try to summarize here the management of hyperlactatemia, not in details. Let's go first to the type B lactic acidosis below this slide. This is the lactic acidosis that you can see with drugs, for example, or due to liver disease or to malignancy. There, of course, you have to treat the underlying cause. But most of the lactate that you see will still be due to hypoxemia, to shock. Then you speak about the type A lactic acidosis, and there you go for the classical ICU therapy of such a patient. Is he fluid responsive? Is his oxygenation okay? Optimize his oxygen delivery? And if, despite correcting and the hemodynamics with fluids, crystalloids or colloids, and preferably with not only with sodium chloride, because you induce an acidosis with sodium chloride, but with balanced solutions. If you optimize your oxygen, and if still then you have an increase or a lactate that is not decreasing, please recheck the reason why the lactate remains elevated, and then treat the underlying cause. This was in a nutshell. Sorry about going so fast, because I wanted to give at least some messages which are important. Thank you very much.
Thank you, Doctor. Now I think we have a few questions. I'll try to skim through the most important. I know that all of them are important, but some of them are general and can be achieved by reading and asking a colleague. But this is what are the common tonic uses. This is general question. What are the why we have hyponatremia with cyclophosphamide IV and not oral?
Yeah, when you give huge doses of cyclophosphamide, it's one of those drugs that gives you a non-osmotic release of antidiuretic hormone. So what you mostly did, what was done in the past was when you treated the vasculitis, for example, with cyclophosphamide, you asked the patient also to drink enough to not to allow accumulation of the cyclophosphamide. This was the wrong thing to do, because we didn't realize that cyclophosphamide gives you a direct release of antidiuretic hormone. So if you force the patient to drink, he cannot get rid of that extra water that he's taking in. That's the main reason.
Okay. Is it safe to give bolus of 3% saline through peripheral IV?
I'm sorry, will you repeat that once?
Is it safe to give 3% bolus saline of peripheral IV?
Well, if the one who asked that question means if it's safe to give us infusion of 3% hypertonic saline, then I would say no. I would reserve my hypertonic saline for correcting hyponatremia as a bolus, so that you can check immediately what the effect is after 1 or 2 hours of your bolus. Better to repeat the bolus if you are not satisfied with the result than give blindly a full solution of 1 or 2 liters of hypertonic saline.
Okay. Does the lactic acid increase with exercise?
Yes, of course. Yes.
Okay.
Yes.
Then I'll ask one question myself before closing. Is that what are the effects of some of the new medications now? Used for diabetes, like Jardians, increasing the excretion of the glucose through the urine. Does that have an effect on the function of the kidney? And we'll close after this.
I yesterday mentioned that, and this is one of the false elevations of creatinine when you start such a drug. How is this drug working? It works by blocking the glucose and the sodium reabsorption in the proximal tubule. So you get glucosuria, so you offer more sodium to the macula densa, to the tubuloglomerular feedback, and the reaction there is a constriction of the afferent arteriole so that you can lower the glomerular pressure. That's the way how they protect against diabetic nephropathy. So the increase in creatinine that you see during the first weeks after starting such a drug does not mean that this really is AKI. It is a reaction you may expect and you should expect to see a beneficial effect on the kidney.
Okay, great. And I think we started 9 minutes late, so we're nearly in time. Thank you very much for the nice, informative presentation. Thank you.
Thank you very much.
Excellent. Professor Dr. Renan Robish, can you share your slide?
Yes, I can.
Yeah. Dr. Bukhari, mic is yours. Dr. Mohammed Bukhari.
Can you guys hear me?
Thanks, Dr. Lemire, for your excellent and phenomenal actually presentation. Our next topic is going to be a very interesting topic. It's a topic about advances in prolonged intermittent renal replacement therapy. That will be presented by Dr. Robish. Dr. Robish is a nephrologist with a wide range of expertise in nephrology that includes adult nephrology, pediatric nephrology, and hypertension. Dr. Robish is a nephrologist at Arcon Children's Hospital, Arcon General Medical Center at Cleveland Clinic Foundation, and he is an associate professor at Neon Medical University and Case Western Reserve University, Cleveland, Ohio. He's a council member for the facility of Internal Medicine Council at Neon. Dr. Robish is a pediatric educational, is a member of the Pediatric Education Committee for the International Society of Nephrology. He's a fellow of National Kidney Foundation and American Society of Nephrology as well. In addition, Dr. Robish serves the National Kidney Foundation Advisory Board in Ohio. His practice includes care of patients with wide range of nephrology aspects like chronic kidney disease, nephrotic syndromes, GNs, tubular disorders, cystic kidney diseases, kidney malformations, neonatal AKI, kidney stones, hypertension, and the list goes on. He also provides medical supervision of dialysis treatment, plasma exchange, and kidney transplantation in adults as well as in children. His research interest is also vast and extensive, I would say. That includes chronic kidney disease and adolescents with chronic kidney disease and their transition to adulthood. Renal replacement therapy, it includes also bone marrow transplantation, and it also includes basic sciences researches that includes non-invasive biomarkers for autosomal dominant polycystic kidney disease. So without further delay, I would like to welcome Dr. Robish and invite him. Dr. Robish, the floor is yours.
Thank you, Dr. Bukhari. First of all, I want to thank the organization committee and a special thank to my friend Khalid, Dr. Khalid Al-Hassan for organizing such a magnificent forum for the pediatric and adult critical care. So my topic is a little bit advanced as in PIRT, and it's just tell my story, like when I was a fellow, how the CRRT was evolving. And most of the work in the PEDS have been done in conjunction with Dr. Khalid Al-Hassan. So he will be visible during our presentations in the form of his academic contribution. So when you start the concept of the continuous renal replacement therapy, there are 4 variables or nomenclatures. Those are SCUF, where you remove the continuous ultrafiltration, or continuous veno-venous hemofiltration, or CVVHD, where you use the continuous veno-venous hemodialysis, and CVVHDF, where you do the continuous veno-venous hemodiafiltration. And this whole thing is evolved the way with the SCUF, with CVVH, with CVVHD, and then CVVHDF. And I have a very nice diagram to depict, and we'll go over one at a time. This is the very basis for the CRRT nomenclature. What is the continuous or prolonged intermittent therapy means? What does C stand for? C is rate or interval for the therapy. If it's continuous, more than 12 hours, it's continuous. What does VV stand for? It's a blood access. Most important part in any prolonged intermittent renal therapy is your good access, good flow, where you can have no problem with the access. And what H stand for? Now, H is a terminology used for the method of the solute removal. So basically, this is what CVVH, the nomenclature was. What is CRRT? How does it look like? So this is your patient. This is a dialyzer, which is basically a M100, M150, or anything that you use. Some of you use the HF filter. If you use the transmembrane pressure for the removal of plasma without any dialysate, without any ultrafiltration, without any replacement fluid, it is known as SCUF. Now, if you give a replacement fluid pre or post, the terminology changes to CVVH, that is continuous veno-venous hemofiltration, because you are using the transmembrane pressure for pulling the UF, and then you're giving the replacement fluid. This is a very important concept. When you use the dialysate, which is now you're using against the concentration gradient, the terminology changes to CVVHD. Now, when you give the replacement fluid and dialysate, replacement should be concurrent. It could be pre or post filter, but when you use dialysate, it's always countercurrent. Then the terminology changes to continuous veno-venous hemodiafiltration. I hope I clear this concept of the mechanism of CRRT. When you look into the recent advances, what is a diffusive process? What is driving the force for the diffusion? It's actually a mass transport coefficient. And anytime when I go for a talk for any international, I was always given to do the mathematics of the hemodialysis, and everybody sleeps during that time. So it's just a mass transfer, and it is dependent on the concentration gradient. If I give you a dialysate with a 0 of urea, with the blood coming countercurrent with 200 of urea, at the end I expect that the diffusion gradient will take all the urea on the effluent with the dialysate. So it's concentration gradient. But convective mass transplant is different. That transport involves the hydraulic permeability of the membrane. So you have to use a high efficiency membrane with a good port size. Then you use the transmembrane pressure, and the very important evolving trend in CRRT is the sieving coefficient, which took me as a fellow to 2 years to understand. I've been trained by Dr. Schreiber, who has been an adult, who's big in CRRT. What is the sieving coefficient when you look into the convective mass transport as compared to diffusive? If you use the CRRT with a blood flow of 200 ml an hour, you are using the replacement fluid 30 ml per kilogram per hour. We assume with such a small blood flow, the sieving coefficient, that is amount of solute removed, is almost equal at the end after your CRRT. So it's considered to be 1. If your sieving coefficient for certain molecule is 40, and then you're also removing with the low blood flow and high replacement fluid, it should be 40 at the end. So the sieving coefficient should be 1. And that concept is very important. It's a very evolving, and you should know that a convective mass transport is not the diffusion gradient. It's a convective mass transport involving the hydraulic permeability, transmembrane pressure, and sieving coefficient. This is a diffusion. What it entails, it just, you have diffusion, small molecule, you can see that it's going across the concentration gradient. You need dialysis. What is convection? Convection is you need a net, again, you need a membrane size, you need a hydraulic pressure. You not only remove the small molecules, but because of the size of the membrane, high ultrafiltered yield, have a high convection, and that causes a remove of the big molecule. And the concept for that CVVH evolving or prolonged intermittent renal replacement therapies, when you go to the seashore, you saw those waves coming in, and when they go back, what you see shells and like big molecules. That's exactly the mechanism. It's coming and hitting the transmembrane pressure, goes back because of the high convective or replacement fluid. You remove the bigger molecule. So that's a convection, and why the convection is evolving now as a mode of therapy for removing the bigger molecule. This is a very good paper by Brenner et al. So if you see the convective clearance, how does the convective clearance is different to the diffusive clearance? Convective clearance is different, dependent on the effluent. As you increase the effluent, you can go for 500,000, 150, 200, with the blood flow keeping the same. You can see the extraction ratio of that molecule increases. But in diffusion, you are stuck. Whatever blood flow you will have, with the concentration gradient, the diffusive clearance is not dependent on effluent. And that is very important, because when you give the post-replacement fluid, you see that the sodium is going down, patient's potassium is not corrected. You can always give the effluent and increase the effluent if there is a bigger molecule. And I'll come to that concept, what we used for the current COVID-19 AKI. This is a very important clearance chart. You can see the convective clearance, sieving coefficient, urea, creatine, uric acid. Vancomycin is 0.84. This is our paper that we have done in CRRT. Diffusion coefficient, 1.9774. So if I have a tumor lysis syndrome and I have a uric acid of 16, I assume and presume with the CRRT, with the sieving coefficient convict being 1, I will remove all 16 if I give the effluent. If I'm not doing that, I'm not reaching the concept of the convective coefficient. You have to increase the effluent. That will help you to remove more uric acid. Same with the vancomycin toxicity. We just published our PCRRT guideline on intoxication. Dr. Khalid Hassan was part of it. And in the vancomycin toxicity, what I do sometimes, I increase the effluent rate, because the sieving coefficient is very, very small. Even if you do the maximum effluent rate, you're only removing 84%. It's a big molecule. But diffusion is a different concept. This diffusion concept coefficient is dependent on the concentration gradient. You cannot increase the effluent. What you can do is you can have a concentration gradient to increase or make this coefficient 1. What is the effect of port size? Creatine, urea, glucose, they move nicely. Vancomycin, big molecule. Albumin, very big, it doesn't go. And immunoglobulins, hard. We have dealt with the multiple myeloma patients, and you need to have a high cutoff membrane. So why this concept of convective theory or hemofiltration is growing? Because it does not only remove the molecules which are bigger in molecules, but it also helps in removing the molecules which are distributed into the intracellular versus extracellular versus in the big compartments. Now, one thing is very important for a sieving coefficient, protein binding is very, very important. And that's why I showed you the vancomycin sieving coefficient is 0.84 because it's binded. And you have a lot of chances that you will remove a bigger molecules. And there is a concept, there are 2,000 uremic toxins in your body. And we just stick on the urea, which is such a dirty mechanism of looking into your kinetics. And that's why the CVVH is evolving into hemofiltration. Is convection better therapy? Yes, because it enhances clearance of those inflammatory mediators, and especially patients with the acute brain injury, fulminant hepatic failure. This therapy is associated with better perfusion, preservation of the perfusion. Now, this you will not like me, because this is something which is evolving concept, and it will take some time. So when we were fellows, we used to calculate the mass transfer. So what are you doing with the convection theory or prolonged intermittent? So basically, it's a mass removal with the blood concentration, effluent rate to effluent concentration about blood concentration. So what you have in the effluent, what you have in the blood, and what you have here as an effluent, which is a replacement fluid. The blood flow is so low. It's like 150 to 200 as compared to the effluent rate, which is like 2,000 ml. 1,000 ml or 15 ml post-filter or pre-filter, the equilibrium, the blood flow almost equilibrate with the effluent. And we assume that at the end, your CE or CB, the effluent concentration and blood concentration is equal to 1. And that is the sieving coefficient for any small molecule. Very important. I always round and tell the residents and the ICU people, it's not the blood flow, it always is the effluent. How much dose are you giving that determines the CRRT. Filtration fraction is very important because filtration fraction will tell you when the circuit is going to go clot. It's an ultrafiltration rate into 100 by the plasma concentration of the stuff that you're removing. And it is the plasma concentration is blood flow into 1 minus hematocrit. Let's do this calculation. When you have a blood flow rate of 100 and hematocrit of the patient is 30, then your plasma concentration would be 70 ml per minute. So a filtration fraction of 30 promotes filter clotting. So in this patient, when the maximum allowable filter fraction is set at 30%, you can use the blood flow rate of 100 ml per minute, and you use the UFR, which is calculated by this formula, 21 ml per minute, which is pretty extensive. And this is how you calculate your plasma filtration rate, that is the filter plasma flow in ml per minute. And filtration fraction is now evolving more higher up by Dr. Tolwani and his group and her group in UAB. And now they're taking into account all the other effluents and replacement fluid. Improve volume removal. This is what's going to happen. You will remove the fluid from the vascular compartment. With the dialysis, what's going to happen? Intracellular shift, you will have hypotension. But with the patients with the CRRT or prolonged intermittent, you maintain the level with the isotonic replaced fluid. This is a feasibility study in the SLED, which shows that patients can do well with a prolonged intermittent therapy with SLED and have a good hemodynamic perfusion and good clearance. Precision method, this is so important. You have a patient, this is your dialysis machine, and this is patient. We should check fluid balance every 1 hour, 2 hours, 6 hours, 12 hours, and 24 hours. And by the end of the day, you should be precising the fluid volume. You should be managing the electrolyte just by working on your effluent. So precision model is coming along very well with the CRRT or prolonged intermittent. Now, CRRT comes in several flavors: solute, transport, diffusion, convolution, ultrafiltrate. Approximately it's a one compartment model. It is dependent on the membrane characteristic, effect therapy, fluid composition rate. Multi-organ dysfunction. The most common cause leading to CRRT was cardiocirculatory shock and sepsis. Overall survival is 49%. And despite CRRT, MODS has a high mortality. What is the role of PIRT in inflammation and metabolic syndrome? Now we are saying because of the middle molecular clearance, you have clearance of the cytokines, you can do the energy supplementation with anticoagulation, you can prevent or induce some anti-inflammation, improve energy balance and metabolic adaptation, may lead to kidney injury and promote kidney recovery. And that is what it is coming as evolving trend for PIRT. It can balance your energy. Most of these patients are critically ill. They have a critical care illness. They use their muscle mass for catabolism. They go into negative catabolism. This is a paper in Nutrition Guidelines, which we did a publication. You can give, and the TPNs and other associated with the CRRT maintain the energy balance. Now, there was some concern about the SLED in the developing country. We use an adult in our center too. You can use SLED without heparin, and this is a paper which was published in PLOS and which we have shown that you can run 12 to 14 hours of SLED without heparin. Now, fluid therapy is very integral to the acute resuscitation and critical ill because, as I told yesterday, anything about 10% is hard. Fluid overload in CRRT, 29% mortality with less than 10, 43% with 10 to 20, 65% with more than 42% of fluid overload. This is our papers which has shown the same. We started the concept of early CRRT and fluid resuscitation with VOD, which is, we are writing a guideline with Dr. Khalid Hassan using the AKI BMT. And this is what we have published, and people are working on the fluid overload. This is the way you can, principle of fluid management in CRRT, you can do it very well. You can adjust your UF, you can adjust your replacement fluid, depends on the difference between all intake and output, including CRRT for any given period. Now, I's and O's in CRRT is what you get out. Out of that, you can decide your UF. So fluid regulation is more controlled with the convective and diffusive theory. Which is better, CVVH or CVVHD? Nothing is better. Everything is same. There's no randomized control trial. CVVH is better, CVVHD is better, CVVHDF is better. SLED, what you have, just do it. Make sure you give the delivered amount of dose. Most controversial part. People go into the high dose. They want to give 50 ml per kilogram per hour. You can see that this is a nice diagram. Your best practice region is between 20 to 40. And this is no benefit from the higher dose. You know, the renal trial and ATN trial, you can see that renal trial used 25 versus 40 milligram, no difference. Dr. Tolwani's paper, 20 versus 35, no difference. ATN trial, 35 versus 20, no difference. What you have to make sure is you clear the solute, you adjust your effluent, and that will help you to maintain. Make sure you get the delivered dose, because these patients will go for MRI, they get for surgery. So at that time, and I know the patient is going for the surgery, I just got a call in the morning, patient is going for abdominal surgery and is going at 4. I cranked up the total effluent dose of 50 ml per kilogram per hour, because I know by the time he comes in, CRRT will not be put in till the end of the day. So higher dose has no effect, but make sure you deliver the amount of dose you want. Step 1, determine the effluent rate. Need to meet the clearance. I'll start with 30. Determine the fluid balance need for the patient. Determine the composition of replacement fluid and dialysate. I don't use low-K bath because they get, it's a convective diffuse, so they get hypokalemic soon. Determine the timing and achievement of goal in monitoring the patient. What do you want to achieve? You want to achieve the fluid goal, you want to achieve the electrolyte goal, you want to achieve the nutrition goal. That needs to be determined, and that is what is advancing a lot in CRRT. RCT have not demonstrated any mortality benefit in starting RRT early versus late. I have a paper, which is, I thought it will be my paper when I'll retire, but it got published in my mid-career, just in therapeutic apheresis, where I said, changing the terminology from a kidney replacement to kidney support, because in adult world, they don't understand about the fluid overload acid. When I go and talk to them with my peds head, they look at me and they said, what do you mean? I'm going to start the CRRT on the fluid overload. So that paper got published, and it was so nice that the editor sent me an email and saying, wow, this is something people need to know. So it's kidney support, it's not kidney replacement. And this is what you have to decide is the drug dosing. We have a very nice paper on CRRT. You include the clearance of the CRRT, residual renal and non-renal. Now with CRRT, patients are anuric, so you don't have to worry about it, but non-renal, not always available for the drug. So this is just a calculation. I'm going to go further and I'll make sure that I'll send it to you. This you have to calculate. I used to calculate when I was a fellow how much the drug clearance would be. But they're just giving you an example about how you clear the drug. This is a paper on the SLED, which came out for the developing countries, that they can dose, how to dose these antibiotics. It's there. You have the protocol there, but make sure you should be careful for the non-renal, not always available for you for the drug. You need to talk to your pharmacist. Now, drug susceptibility of susceptible pathogens and drug concentration should be considered when selecting drug regime. When you are in doubt, you don't know what to do. In CVVH, dialysate flow rate usually should be 2 liters. CVVH substitution rate should be 2 liters per 1.73 meters squared. Add this to the patient's native creatinine clearance. And this is patient's new creatinine clearance. You dose accordingly. Work in most cases is good enough for initial estimate. Then you can have a follow the drug level, because there's so many drugs coming in. When I was taking care of the COVID patient, I was like, oh my God, they're getting IL-6 inhibitor. They are getting so much of antiviral medication. So best thing is, if in CVVHD, usually dialysate flow rate, CVVH, you start the substitution fluid. Do not take or negate the creatinine clearance off the machine, because you can calculate with the CV coefficient how much you are clearing with that fluid. And then you add to the native creatinine clearance, and you can be always good with that. CRRT management of ICP, you need to have CRRT because of the prevention of the intracranial pressure. Key point, I guess, said that you have to have CRRT for this. Now, new paradigm shift in AKI followed COVID-19. Here I'm dealing with the patients who have a chemokine burst. What can we do? Because if you are stuck, this COVID is releasing cytokines, interferons, inducing macrophage inflammatory response, tumor necrosis factor. And then I applied all the advances now. You need a CBVHDF for a high molecular weight clearance. You need a good replacement effluent dose to maintain the hemodynamic stability. This is Ronco's paper, and then I kind of modified in my presentation. You can see these interleukins are coming in. You have a chemokine burst, and you need to inhibit this interleukin response for 12 hours. Either You can do it with CVVH. What we have proposed in our paper was a high flow, 50 ml per kilogram per hour for 12 to 24 hours, so that you can remove the middle molecule. You can use it with ECMO. We have put that machine. Don't use just filter to the full CVVHD with effluent. Or you can use a cytosol, which is expensive. I have only used one. We are using auxiliaries that absorb these chemokines, and it is put in parallel with the dialysate. So the concept is now not only evolved, we have this to put into perspective in the era of COVID-19. Anticoagulation. What we will suggest, we prefer citrate. Heparin is good if you do not have either. Just increase the pre-replacement fluid to make it better, or you can give pre-filter normal saline. We prefer citrate, we prefer bicarbonate-rich fluid than lactate, but it is all guidance with it's a consensus statement. There is no randomized control trial. You do the best, make a circuit life better, however is preferable in your institute. Site of action of citrate, we all know how does it helps in the activation of 12, 11, and 9. Then you have this, apart from these anticoagulation, it also have the effect of monocyte platelets and also the macrophages. And that's why we are saying maybe with anticoagulation, we are inducing an anti-inflammatory. This I get every time when I round. All of you get this question. When are you going to stop the CRRT? No consensus in nephrology or critical care literature. Urine output is the most important predictor of successful discontinuation. Greater than 400 ml per 24 hour without diuresis, or more than 2300 ml per 24 hour with diuretic, greater than 80% of the chances that you will be successful in taking out. Discontinuation of CRRT, a postdoc analysis which is done by the critical in 2009. So this is what you have to decide. This is for the kids, or this is for the adult without or with diuretics. PRRT advances, with that I want to say it is a good availability with the convective diffusing, that you have metabolic adaptations with AKI result. You have most common treatment in septic AKI. You can remove the inflammatory cytokine, neutralize the increased inflammation to reduce kidney injury and promote kidney recovery. There is a clearance of inflammatory cytokines such as MIF promises to play an important role in reducing kidney injury and promote recovery. It is just a hypothesis, but this hypothesis proved very well in the patients with the COVID. Decreased level of IL-1 beta IL-6 can neutralize the excessive metabolic adaptation and promote kidney recovery. PIRT can provide extra energy supply to improve the kidney energy balance in septic AKI. MODS, anticoagulation used in PIRT, can also regulate the inflammation in septic AKI. PIRT is a treatment not only to deal with the water balance in metabolic product, but also to regulate the inflammation and sepsis. Advances in the mode and the membranes are investigated and promises to be helpful in the treatment of sepsis. And this is what we did. We have Auxeris, which is H14, which is like almost HF 1400. And we got approval in April for the FDA for the chemokine response. And I have used it so far in 6 patients, good response. With ECMO also it works, but we always do it for like 12 to 24 hours. You have to be careful with the chemokine concept, because sometimes the critical care people think that excessive removal after 24 hours, you are removing the good chemokines, because you know that IL-10, IL-6 and TNF-alpha are bad prognostic sign for the AKI. IL-12 is actually shown, I did that presentation yesterday, is actually protective for the AKI. So our protocol is used for 24 hours, these patients they call. At the end, I just want to let you know the CRRT has evolved since I was a fellow. Convective theory is helping. Yeah, so convective theory is evolving. Good dose, calculate your effluent, look what you're looking at, the big picture will help. And this is going to growing evidence down the road. We'll get more trials to see. It's hard to do randomized control trial in these sick patients. But a good example of this evolving concept is your COVID-19. And we have put that concept for interleukins by using the auxiliaries and cytosol. With that, I want to thank the organizer and Dr. Bukhari, and especially my friend Khalid. Khalid has been very energetic, and he has really taken the concept of critical care in your area to a very high level. And I have actually interacted with him in various collaborations. And it was very nice to see how Dr. Khalid Al-Hassan is taking the concept of the AKI with CRRT in your country. With that, thank you.
Thank you very much, Dr. Abushrina. I think this was very, very interesting topic, and very nice presentation. I would like to ask about the anticoagulation in CRRT and PIRT. This is one of the challenges that we face when we use CRRT. The most common strategies, I would say, no anticoagulation, heparin or citrate. However, every one of them has like a price tag attached to it.
Right.
So,
So rightly said.
I think there was some like reports of using other anticoagulation strategies like danaproid, antiplatelets, prostacyclin. Is there anything promising going out of them? And along that line, I think there is somebody, Dr. Turki Banama, I think, asked the same or similar question about anticoagulation, especially in particular in patients with hepatorenal syndrome, when both heparin and citrate are probably contraindicated.
So thank you, Dr. Bukhari, because this I deal every time. So let me answer this wearing my adult hat, then I will answer in the setting of peds hat, because I have to respect Dr. Khalid Al-Hassan for his pediatric nephrology. So let me wear the adult hat here. When I'm rounding in the adult, I am doing a lot of CRRT. Like on an average, I'm managing 15 to 20 CRRT. Citrate needs a lot of intensive monitoring, one-to-one nursing, ICAL measurement, and also citrate is considered to be a drug that given during when you give them in the CRRT. Heparin, most of the ICU will not like heparin. Half of them, they have sepsis, DIC. So heparin is kind of when I used in a setting where it's not like DIC or septic shock. What I personally do, what you said initially, is the best thing for us is not to use any anticoagulation in the start, then see how the things move on. So in adult, what I do, and in peds I cannot, because in peds I do everything post-replacement. So what I do is I decide my replacement fluid. So suppose if I'm giving total of 4,000 ml per hour, what I do is I give 1,000 as a dialysate, because most of these patients, electrolyte is not an issue. It's basically diffusion is not what you need, because even with a liter of ml an hour of the replacement fluid, you can adjust potassium, you can adjust acidosis. What I do is I give 1,500 pre-filter and I give another 1,500 post-filter. So I dilute the blood. As I showed you, the blood flow in the CRRT is 150 to 200. By the time it comes down, it gets hemoconcentrated because your replacement fluid is like 2,000. So I give pre and post. Now, when you tell us to the pediatric world, they get all worked up. Oh my God, you are giving the replacement pre-filter. What's the big deal? If my electrolytes and my issues are not getting better, I can always increase the post filter. So when I go back and round, which I was saying the precision matter, after 2 hours, I go and I see acidosis is not getting better. They are still hyponatremia, hyperkalemia. I increase the post replacement fluid to 2 liters. So that will give you a circuit life of at least 48 hours. And then you can decide patient can be on citrate or not. Because if you start initially with citrate, the lag time of setting up the machine and getting citrate is 6 to 8 hours, at least in our institute. By the time it goes in, the line is in. So you just nailed it when you said we should use one without. I don't use prostacyclin. It's not approved in US. I'm still struggling with my citrate and heparin I use for CVVH in a special setting. Now, when you have these patients who are hepatorenal, they are sick, transplant patient, I generally go without. Now, when I come to the peds world, peds is favoring citrate. Heparin is a little bit hard. Plus in peds, if you're rounding, you have 2 or 3 patients on CRRT, right? And you can adjust and give all post replacement. So, but you nailed it out, these new medications, prostacyclin and other, I'm struggling with the citrate right now. Bringing these new medicine on the floor, I will never go home. So I need to just kind of pick up the structure, what you have. So if you want, in the middle of the night, I just do pre-filter, almost 1,500 of replacement. And that's around almost more than 1/3 or 1/4. And you will have a problem. You're diluting the blood, but it's okay. You can always replace it with post replacement. Nobody knows. There's no randomized control trial, which is better, right? So that's what I will answer.
Great. So one more question, because I think we run out of time. The question that was like repeatedly asked is about AKI-induced COVID-19, AKI-induced. Is there any preference in terms of what to start? What modality of CRRT you would start, and early versus late initiation of CRRT? Is there any benefit favor?
Very good question. Very good question. And this is what actually we have published in the Frontiers, our guideline for PCRRT, and we are following in adults. So what happened with the COVID-19, you have this systemic cytokine storm. And these are all the cytokines that you have when the patient come in the AKI. Your time frame for first 24 hours is very critical because you have to stop this cascade of the chemokine response so you don't get the endothelial damage or renal failure and further lung damage, ARDS. Now, three things you can do. Number one is you use the high flow CRRT that we have done. We suggest using 50 ml per kilogram per hour. You can use a high flow so that you will have more convective clearance, and they clot very early too. They are very hypercoagulable. So at least do that if you have CRRT. If you have SLED, you can use SLED-F, which is diafiltration. And there is no data to say it is contradicted. No, it will help. It is still diffusion with filtration. You will get the same mechanism as you get with the Prisma. Or if you are advanced, I don't use CytoSorb, but we use Oxiris, which is actually a filter that takes the interleukins. It absorbs the adsorption method, like a hemoperfusion that we used to do with the various kind of toxicity or charcoal thing. And then you connect in parallel before the filter. So you remove all these interleukins, then you let the blood go through the CRRT filter and give the patient back. First 12 to 24 hours is very critical for these patients. And I have tried 5 or 6 Oxiris so far, because it was very hard for us to get an FDA approval. And we have a good response rate, but again, I cannot disclose the data. It depends on the patient's sickness. So you can use SLED, but use SLED-F. If you're using CVVH, I will recommend you to use high dose 50 ml per kilogram per hour, which is contradictory what I told you, that high dose doesn't show any efficacy, but they are very hypercoagulable. Does that answer your question?
Yep. Thank you very much. I think we will end it up here because I think we invaded the time of the next speaker. So thank you very much, Dr. And I will end it here. Thank you.
Thank you very much. Can you share your slide, Professor Raymond? Professor Van Holder, share your slide. And the mic is your, Dr. Ali.
Thank you, Khalid. Okay, our next speaker, Professor Raymond. Professor Raymond is a biologist and published over 100 papers. He shared many and was a member of the KDICO guideline. He was the chairman of the European Renal Best Practice, and he's president of the European Renal Association, and currently he chairs the European Kidney Health Alliance, which is basically focused on patient care. He has been publication on vascular access, and he's going to tell us about guidelines and how to take care of vascular access, which is a very important topic for our practice. Professor Raymond, please.
Okay, do you hear me?
Absolutely, yes.
Okay, thank you very much. Good afternoon, everybody, and thank you very much for the invitation. I'm quite impressed by your efforts and by the number of participants, which I still see growing every minute. We are now above 3,000. I think I never have been speaking for such a large audience. So that's quite exciting. I have been asked to discuss with you the recent clinical practice guidelines on care for arteriovenous access for hemodialysis in adults. And before starting, I just would like to specify that part of the slides I will use have been provided by European Renal Best Practice, who were the ones who produced the guidelines. Part of it also was generated or given to me by my previous coworker, Evi Nagler, who is a methodologist or was a methodologist at ERBP and was the vice chair. And then I will use also some of my own material. And this guideline was a successor of something that we have produced previously when ERBP still had European Best Practice Guidelines, or EBBG as a name. It is a vascular access that was published in 2007 and has been used and referred to quite often. But of course, it was absolutely time to renew those guidelines, and the way they have been, the recent ones have been produced, are obviously different from what we were doing at the time, with a much larger group of people participating in development of the guideline, but also with support of a large methodological team who are trained in using evidence-based methods. And these were on their own already 8 different people. So in total, the guideline development group, in comparison to the relatively small group in 27, were 9 surgeons, 25 nephrologists, 3 radiologists, 5 researchers, 2 nurses, and then the 8 methodologists mentioned. And these guidelines were also checked by a patient. And in total, this gave us a lot of opportunity to produce the best quality that we could obtain. Before going to the guidelines proper, I also would like to review briefly with you a number of background data on how this was produced. And first of all, the guidance body is using a number of tools that are provided in literature about proper development of guidelines. One of these has been produced by the US NIH. Then there is also an Adapti system, an Agree system, which I will explain briefly in the minutes to come. Also grade system. And then there is also a kind of a tool for guideline development. So all this has been used. All this was not in use in 27. And this generates a number of guidelines, of which the way of scoring them is also interesting to explain, just to know how the convention is. So there are 2 grades of a guideline of recommendation. One is strong, and that means that we give it the number 1 and the connotation in the sentence we recommend, and that means that evidence is quite convincing and that there is quite a lot of support of following a certain attitude or intervention. Whereas if the recommendation is not that strong, if it is weak, then the terminology is we suggest. And then, of course, there is more of a hesitance about using a certain attitude. And in general, it may be necessary to take into account specific elements of the place where the intervention is happening, and also the condition of the patient, whether or not to follow a certain attitude. And together with this comes a number of indicators of evidence, and those are 4, and going from A to D, from high, moderate, low, very low. High mostly means that there are a number of consistent randomized controlled trials. B is a little bit less supportive. It means that there is some contradiction in randomized controlled trials, or we had to use very large observational data. And then if we go to C and especially to D, then we have very low. That is the old opinion-based recommendation. So of course, usually you will have 1A, 1B, and then 2C, 2D, but sometimes you get something that is deviating. And for instance, 1C, a quite strong recommendation, although the evidence level is low. The agreed to system is a system that assesses with 7 different parameters or 6 different parameters the reliability and the quality of the guidelines. In this slide, you see the comparison of what we did in 2007. That's the red bars with the current guideline in the green bars. So it is clear that for most of these parameters, quality of this recent guideline was better or at least the same as of what we produced in 2007. And then we had this kind of cascading approach where first of all, after a literature review, 39 topics were identified, were subjected to the screening of more than 1,000 clinicians and about 100 patients to prioritize a number of topics. And from those topics, 39 in total, 20 by another group of 425 clinicians and 50 patients were finally selected to develop this part 1 on peri and post-operative care. With this other connotation that these guidelines are supportive of clinical decision-making, so it's a helping tool. It is not a law. It is not intended to prescribe standards of care, so everybody is free to follow or not to follow, depending upon his own opinion and perception. And as already told, we had 20 topics. Normally, we should have distributed them around 4 different main issues: central vein catheters, care of the vessel system before the vascular access intervention, and then the treatment and approach around the perivascular access treatment, and then post-vascular access. And for time and money reasons and practical reasons, it was decided that we should take only the peri and post-vascular access as first, with the intention to do the vascular access and the pre-access later on. But in the meanwhile, I got news that ERBP was stopped by the ERA EDTA. So probably unless the opinion is changed, those second set of guidelines will never be developed, or at least not be developed by ERBP. And then there are a number of topics that that have been discussed. Of course, for time reasons, I'm not in the possibility to discuss with you everything, and I had to make a selection. And before starting, still 2 different things that you need to know. There are 2 very strict dichotomies in this guideline. The first is that we make a distinction between arteriovenous fistula and arteriovenous graft for obvious reasons, because sometimes a certain intervention is okay for the fistula and not for the graft, or vice versa. And a second distinction is between maturation and maintenance. Maturation meaning the period of the development of the access between surgery and the first puncture, and maintenance, what is happening later on. Because, for instance, a certain intervention may be okay for maturation, but have no effect on the maintenance phase, or vice versa. And in what follows, I will discuss with you a selection of guidelines. If the appreciation of the guideline is yes or green in color, then it means that the guidance body was in favor, positively in favor of a certain intervention. The red is meaning the opposite. Then we were clearly against, and neutral means that no decision is taken, and it is open to the person who does the intervention or considers the intervention to outweigh the pros and cons. And then there are 4 different columns with, first of all, the appreciation by ERBP itself, but also for comparison, the decisions taken by the European Society of Vascular Access, by Spanish vascular access guidelines, and entirely to the right from UK guideline bodies. And here we go with the different guidelines. The first are about treatment for AV fistula maturation. I remember the distinction between maturation and maintenance. So this is purely about maturation. The question, should we use antiplatelets, gives a neutral guideline from ERBP, as it is also the case for the Spanish guidelines, and the same is for heparin, and the same for far infrared. But as far as the two anticoagulants is concerned, this decision is mainly due to the fact that one should always outweigh the advantage of potentially maintaining the vascular access system in comparison to the risk that there is for bleeding. Because the systematic review that we were using on more than 500 interventions obviously was in favor of antiplatelet use, but nevertheless in the formulation we wrote that there should be a balance in considering the reduction in thrombosis against uncertain effects on maturation and bleeding. And as a matter of fact, as an illustration, I show you this study in JASON on antiplatelets a few years ago, where it is clear that as compared to placebo, the broken line with antiplatelet, the bleeding tendency was certainly a negative aspect. So if we have to outweigh, we have to consider, especially if a patient is at bleeding risk. On the other hand, it is clear that for other reasons like stroke or whatsoever, quite some of these people are already on anticoagulant medication. And in that case, of course, a positive effect on the fistula system or on the access system is well taken. And then, of course, this offsets more or less the bleeding risk, which for other indications is not as much of weight, apparently, as for vascular access. So same for heparin and infrared. Then a very positive guideline, like for the other guidelines bodies on hand and arm exercise to promote the progression of the fistula development, and also in favor of regional block anesthesia versus local anesthesia. Finally, for end to site versus site to site, there was a neutral guideline, which means that there is no real data showing a favorable outcome for either of both, so they are considered to be more or less equal. For antibiotic prophylaxis, the guidance is clearly negative for arteriovenous fistulas, which means that there is no benefit of using this, only a risk of creating antibiotic resistance. For AV grafts, on the other hand, and that is conform with the other guidelines, the guidance is positive. And here you see an example of a strong recommendation, number one, in spite of the fact that the evidence is rather low. For the treatment of non-maturation surgery versus endovascular intervention, there is no real decision. So that means that both are equivalent, and that the decision is left to the unit or the doctor in charge, and largely will depend on the experience of that unit with one or the other intervention. So you should not do something opposite to what you experience to be beneficial. Never change a winning team. The timing of the cannulation. Clearly negative about puncturing AV fistulas less than 2 weeks. Very much in favor of more than 4 weeks. The question is, of course, what about the gray area between 2 and 4 weeks there? The guideline says that normally one should not use it, but it may be considered if in this way one avoids the use of a central vein catheter, and one may consider a temporary use of single needle dialysis to allow treatment if the development of the fistula is not sufficient. For grafts, puncture is also clearly negative. The advice is negative, with the exception of grafts that have specifically been developed for an early use of the access system. The reason why we oppose against early cannulation is illustrated in this DOPS analysis, which was performed on a very large number of patients, but where it is clear that if the access is cannulated, in this case, a graft, where the guideline allows puncture after 14 days, that the outcome is obviously better if this is occurring in comparison to when this would be occurring too early, comparing the upper line for more than 14 days to the lower one between 0 and 14 days. And then there is also a whole section on puncture techniques. There are different possibilities, of course. This is the area technique. That means that puncture is performed on virtually the same place all the time, not exactly the same place, but in the same area. The second is the rope ladder. That means that one is moving along the access system with a number, let's say about 10 different puncture sites that are used in a consecutive way, and where one returns to the original puncture from the moment the last puncture site has been used. So one is moving along this road all the time from one direction to the other. And then the last one, quite often preferred by the patients themselves because it causes less pain, the buttonhole technique, where one is puncturing exactly one site, always the same time, as an access method. So the question is, of course, which one of these three is to be preferred, and that is explained in the next section, where it is clear that the area technique is discouraged, that no clear decision is taken in favor of rope ladder versus buttonhole, and this more or less is a little bit more careful attitude than, for instance, the Spanish guideline. And about buttonhole for short segments, no specific decision was formulated. The basis of this is this other extremely large observational study where there was a quite huge better relative risk for the buttonhole and the rope ladder as compared to the area technique. The buttonhole, however, and that is also formulated in the guideline, has one caveat, and that is that it is increasing the infectious rate. In this paper by Muir and co-workers in CJSON, it is clear that you get a significant increased risk for total infection and systemic infection, but this can be easily forestalled by preventive measures and educating versus careful care of the access system, as also illustrated by this observation from our colleagues in Louvain, where you can see that in their home dialysis treatment system, they were using other techniques, then made here the shift to buttonhole. And here you see their infectious rate going up. And then they organized education on how to properly treat in a sterile way the access system, and here their infectious rate is going down. So with accurate prevention, this problem can be avoided. Technical surveillance, which means flow measurement, either by ultrasound or by flow system based by dilution techniques. And here for AV fistulas, we have no clear standpoint for grafts. It is clearly said that it makes no use and that it has no advantage, as illustrated by the color red. The whole debate has been fostered by a number of observational studies in the early days, like this one, I think from Nashville, from Vanderbilt, where in green you see the grafts and in blue the fistulas and the risk for thrombosis, but that's purely observational. So we go from no screening to venous pressure here in the middle, and then screening of the flow later on. And here in this study, you see an advantage of this screening method, both for grafts and for AV fistulae. But then this meta-analysis by Cello Tonelli is clearly showing that for fistula, maybe there is an advantage in thrombosis with access flow follow-up for fistula, but not for graft. Here we are already on the equity line. And if we then go on the long-term outcome, then there is even no advantage anymore for fistula. There may be a trend, but of course there were in this evaluation only 2 studies included. And again, for graft, we are on the identity line. So this is for graft, it's doing nothing. So that explains why we were negative for grafts and neutral for fistulas. So the way it is expressed is that technical surveillance with fallout, of course, by correction, may possibly have a positive effect for avoiding the stenosis of AV fistula, but not for the risk of permanently losing it or only very slightly. And for grafts, there is no advantage at all. So that's the reason why the color is red for graft. If there is a thrombosis, the timing of the intervention is as soon as possible. So that brings us to the conclusion of this presentation. Potential advantages of anticoagulant prevention must be outweighed against bleeding risks. AV fistula should not be needled before 2 weeks and preferably only after 4 weeks. AV grafts should not be needled before 2 weeks unless early cannulation venous grafts are used. The area puncture technique is discouraged. Buttonhole technique may necessitate specific care and training to avoid infection, and technical surveillance to avoid thrombosis has no sense in arteriovenous grafts. I thank you for your attention.
Thank you, Professor Raymond. Thank you for being on time, and there is enough time for questions. It's a great talk, and let us see the questions. The first question, can we use AV fistula in patient under CVH treatment, or this is absolute contraindication?
Under which treatment?
CVVH, I mean CVVH.
CVVH?
Yes.
I would not be, I actually don't know whether this has been studied, but I would not be too much in favor for using an arteriovenous fistula for a technique for which it has not been developed. I mean, CVVH is going on continuously, and I'm not sure whether this is really an advantage because, of course, the fistula has been, the concept is that at least it has some time to rest and to restore in between. I am also not so sure because the flow rate in CVVH is, of course, much lower than, or CVH, in CVH is lower. Of course, maybe the risk for clotting is also higher. And as this is intensive care and usually a central vein catheter is placed, I would rather think of this technique going on that rather than a fistula. For the same reason, I'm quite definitely opposed of using an arteriovenous fistula for blood puncture, for instance, in a patient who comes in and needs to be taken blood if it is not combined with dialysis.
Okay, clear. I have a question. In our practice, surgeons usually, they prefer or they are asking actually for antibiotic pre-operative, 6 to 8 hours, and followed by another dose. Is there a real strong evidence in this practice?
I mean, yeah, I think as you are using foreign material for a graft, of course, the risk of infection over there is more important, I think, than for a fistula where you're using endogenous material. There are studies that are showing that there is an advantage of using those antibiotics in arteriovenous grafts, so that is improving the outcomes, and that is the reason why the guideline was formulated as such. I don't know by heart the evidence level. It's must be over here. Yeah, it's at the beginning. Yeah, so 2D. And no, 1C. So that means that by experience, I guess the people who constructed the guidelines know that it is of use, even if the studies are not so really convincing. For AV fistula, first of all, because of the endogenous material, it was thought that there was not really an advantage. And that is to be combined, as I explained during my presentation, with the risk to develop or to cause antibiotic resistance. So that's the reason why the guideline developers took in consensus a relatively careful attitude. Does that answer your question?
Yeah, it's clear for me.
But of course, feel free not to follow the guideline that I explained also.
It's individual anyhow, you know, it's use the right access at the right time for the right patient. It's very important. We have a few questions. Maybe we can post it later to get an answer, but there is a question says, when we can use the brachiobasilic fistula after
Can we use what? Sorry.
Brachiobasilic fistula after transposition or superficialization.
Rescue, I think I leave this kind of decisions and intervention entirely up to the surgeon. I think any way to rescue an arteriovenous fistula, if the technique is well known to the surgeon, is very welcome, because of course any access system that is abandoned and that necessitates you to go to a further section of the vascular system is one step backward up till the moment that you don't have an access system left. And I don't know what is your experience, but in my experience, at least, it happened 4 or 5 times in my life that everything was exhausted, that we also could not perform any more peritoneal dialysis, and that the patient was in risk of death and also no transplantation, so that the patient was in risk of death because we had nothing anymore. So the way to work is to go as slowly as possible to the next step of breakdown.
Yeah, great, thank you. We have more questions. Yeah, in the guidelines or recommendation in general, is there a specific time how frequent you do checking for stenosis, or it's just to be done when there is a suspicion like blood flow or venous pressure high? Or
the guidelines as they are formulated are considering the regular, let's say, systematic assessment. So if we do it or did it, at least at the time, it was done every month or every 2 months, because I think if you are waiting for suspicion, then and if the intervention has any sense, then if you are waiting until the clinical condition necessitates it, then you may come too late. And to my opinion, in that case, I even would trust rather my clinical judgment than the judgment of flow measurements. Our experience with this especially has been the huge fluctuations that you see from one moment to the other. And for that reason, I think it's a quite tricky thing. But yeah, as we say, for fistulas, it's open for discussion. You can do it. But then you need to be consequent. And when you see that your flow is going down below a certain threshold, then you have to perform radiology or visualization of the system, and then discuss with your surgeon what you will do.
Great, thank you.
Don't forget to look at the access system clinically and listen to it and look to it. Sometimes you may also learn from that that something is happening.
Great, thank you very much, Professor Raymond. It was a great talk, very beneficial. Thank you very much, and thank you for the rest of the team who's listening to us. We will have a break now, and we'll be back after, I think, 20 minutes. Thank you very much.
No, we'll be back actually exactly 6:30. So we have about 9 minutes now. So we'll start the next talk at 6:30 exactly, after 9 minutes. Okay.
Thank you.
So Professor John DeGardas, kindly can you share your slide?
Yeah, I'll set that up just in a second. See.
Excellent. Full screen, Professor.
Not sure I have the right screen. Let me just try it again. Are you seeing my slides?
Yes, yes, but it need to be a slideshow, so it will be bigger. So.
Yeah.
Yes, yes. No, excellent. Can you put your video on? Yeah, excellent. Now it's good. You went back.
Yeah, I'm trying to show the slides and also to if I have the slides, I don't see the Zoom. I don't see the videos on the side. Is that correct?
No, it will be both. Don't. Yeah, now it's okay. But you need to put your video on. So your video, you click it again. So make it on.
Let me just try that. I see.
Yeah, you cannot. I think probably you need to. Can you probably can maybe stop share, then open your video, then come back and share.
No, I see it now.
Oh yeah, excellent. Now it's good. Yeah.
So now let me just see.
Full screen now.
Okay. Okay, I think this is okay now.
Absolutely, you just yeah, absolutely, it's fantastic now.
Yeah.
So we'll just after. So everyone is hearing us, by the way. So just 6 minutes, then we'll start.
Okay, thank you very much.
Mohammed Bukhari, when we reach exactly 6:30, just start introducing Professor John to guard us. So our audience, so we'll start exactly by 6:30. So just 5 minutes more, then we'll start.
I do have a suggestion.
Sure.
You know, maybe you could have one Zoom camera just on a clock, on a picture of a clock, so that people could be, who are giving the talk and would be very much aware of the time frequency. Might be something to think of.
Okay, I will ask our technical guy if it is possible. Just 1 second.
Yeah, usually, you know, in meetings, you have a big clock in front of you so that the speaker has some feedback if he's running short.
I will ask Samir, did you hear the...
It could be a separate video Zoom person just logging in and just focusing the camera on a clock, on a timer or something.
Yeah, we'll try to do it. Anyway, we will have the moderator, so he can also.
Now I have a question. Should I shut my speaker off, because then you're going to be getting my audio from both myself and also a reflected audio from my speaker. So should I turn my speaker off?
No. If you turn off, no, you need to speaker is on. So speaker is on and the video is on. So each one.
No, I know the speaker. I'm talking about. That's not what I'm asking. Maybe I misspoke. My own audio, so I can hear myself when I talk. But then when I'm talking, the microphone will pick up my direct feed, but it also picks up the reflected, what's coming in from my speaker.
You can, let us try it now. So make it off, then we'll see if we can. Okay,
let's just try this. So okay, so I'm going to talk now, and now I'm going to turn down my audio.
Excellent.
Okay, now the audio's off. Now my audio's on. There's no difference. Everything is okay.
Everything is okay.
Okay, fine, perfect. Yeah, I congratulate you guys on the technology.
It came from your country. Zoom is American company.
Yeah, my son invested in Zoom. He said he bought, as soon as he figured this out, he bought their stock, and their stock went way up.
Oh yeah.
So
you can see Professor John DeGardas from attendees now. So if you look at it, if you click the button of the participant, you see the number of the attendee currently now. So currently now, 3,285 is available in the room.
yes, that's very impressive.
قفل الباب.
Muhammad Bukhari, you can introduce Professor John DeGartas. Muhammad.
Okay, so welcome back, everybody. I would start the second session for today, which we will start with a very interesting topic titled Modern Integrative Look at Different Aspects of Dialysis Adequacy. Dialysis adequacy is one of the challenges that we are facing in dialysis modalities. The presenter for this session, for this topic, is going to be Dr. John DeGartas. Dr. John DeGartas is a nephrologist who, for a number of years, has been interested in how best to treat patients who have chronic kidney disease with various forms of dialysis therapy. Currently, he's a clinical professor of medicine at University of Illinois, Chicago, where he has received the Chicago Top Doctor Award for multiple years. His research activities include participation in 2 NIH-sponsored studies, including the famous HEMO trial and frequent hemodialysis network trial. And he was involved in the group that designed the chronic renal insufficiency cohort. Dr. John DeGartas is currently studying how much dialysis to give using various schedules, as well as factors affecting blood volume and blood pressure during hemodialysis. He also has a special interest in nutrition as it applies to chronic kidney disease and phosphorus balance. Dr. DeGartas has particular interest in medical education, and he is a co-editor for the Handbook of Dialysis, editor of Handbook of Chronic Kidney Disease Management. He's also a founding editor for educational website Hypertension, Dialysis, and Clinical Nephrology. So without further delay, I would like to welcome Dr. DeGartas, and the mic is yours, Dr. John DeGartas.
Good, thank you. Can everybody hear me?
Yes.
You can hear me, good. Yeah, thank you, Mohammed Khalid. Thank you so much for inviting me. It's a shame. I was looking forward to visiting your beautiful country in person and had everything all set up, and COVID disrupted that plan, but congratulations for everybody for this wonderful technical achievement and for getting such a large number of audience. I really appreciate it. So today I'm going to talk about dialysis adequacy and not talk about the math or KT over V, but in a more holistic sense. And if I could, trying to find out, interesting. These are my current disclosures. So the question is how we define adequacy, and people have been focusing on duration of life, but this may not be the most important for dialysis patients. What about cardiovascular health, blood pressure, left ventricular mass index, whether they get heart attacks or congestive heart failure, nutritional status. We know dialysis patients have problems with weight, maintaining their weight. They tend to lose weight, lose muscle mass. We can assess this with subjective global assessment, looking at serum albumin. Most people start dialysis with some residual kidney function. So the question is, are we hurting residual kidney function by our dialysis technique? Can we preserve it as much as we can? Physical functioning is very practical, ability to perform daily activities, cognitive function. We know dialysis has been associated with depression. Can our dialysis procedure prevent this? What about symptoms? Very important to patients is the post-dialysis recovery time. Sometimes this can be as short as a few minutes after dialysis. Sometimes patients will feel terrible for the whole day after and even into the next day. Patient burden. We talk about doing dialysis and dialysis every day. But it's an incredible burden sometimes, not only for the patient, but also for their family who has had to deal with their illness. They have social issues, family issues. And then something that people very rarely talk about is rehabilitation. What type of dialysis procedures will help patients return to work and remain productive members of society? So there are a number of factors that we know affect survival, cardiovascular events, and physical functioning. Modality choice with preemptive transplantation, residual kidney function. KT/V does affect survival, but not so much after a minimal level is reached. Weekly dialysis time, there have been many papers looking at dialysis session length and survival. What about convective clearance? The new hemodiafiltration studies with high convective clearance. Interestingly enough, something as mundane as dialysate temperature has been shown to improve survival in at least one study from China. And then the study is the thing that most people are interested in is frequency. Can we do incremental dialysis, starting people off at 1 or twice a week? And then as patients lose residual kidney function and need more help, then we switch to 3 times a week, and then we add a 4th treatment, and then even a 5th treatment in some patients. And issues of home versus in-center dialysis. Factors affecting patient comfort and burden include modality choice, PD versus HD. PD, of course, allows people to travel. That can be done more in the home. Now with some of the next stage and other home dialysis systems, home hemo has become more practical. Dialysate temperature affects not only survival, but there's some studies by McIntyre that it may maintain cognitive function, and it may reduce post-dialysis recovery time. Home hemodialysis impacts survival and patient satisfaction, and dialysis frequency, even at the cost of a slightly higher patient burden, has been shown to increase physical functioning. So the first decision point we have is when the estimated GFR is around 20, then we decide on modality choice. Patients are instructed whether they go on hemo or PD, or very important preemptive transplantation if that's a possibility. This has excellent survival. And then once the GFR falls to around 8, then we talk about palliative care, and again, PD versus HD. Within PD, we have the decision point of automated dialysis or CAPD. And then within hemodialysis, we have the choices of home versus in-center, and frequency, dose, KT/V, and dialysis time. So many decision points. When we see a patient with hemodialysis, we have to consider the residual kidney function and how much urine volume they're putting out per week. Looking at the weekly fluid ingestion, how much they produce over and above insensible loss, and especially that which is not excreted by any residual function. That's what has to be removed. Then we have to look at whether there's left ventricular hypertrophy or other structural cardiovascular disease. Is home dialysis available? This allows for easy every other day dialysis, short daily schedules, which are very difficult to implement in center. And is in-center nocturnal hemodialysis available? This is a schedule that's now is increasingly available in the United States. All of the dialysis time is in the nighttime, allowing patients daytime to be free to work, to spend with family, and also allows for increased weekly dialysis time and a lower ultrafiltration rate. And relevant to US patients, is hemodiafiltration available? And in the US, where we're protected by our Food and Drug Administration, perhaps excessively so, this is not a widely available therapy. Now, we know residual kidney function is very important. It leads to better, patients with high residual kidney function have better survival. They have less LVH, better phosphorus control, better physical functioning, lower ultrafiltration needs as the urine volume is subtracts from the amount that needs to be removed during dialysis. There's evidence that residual kidney function, we KR, and KR is the abbreviation for residual kidney clearance. U stands for urea. It may be better maintained on PD. And then if it's higher than 2 to 3 mils per minute, and if urinary volume is less than 500 to 600 mils per day, it may allow for a two per week schedule, as long as that residual function is maintained. The other reason is if a patient has high residual kidney function, there may be little or no benefit of frequent dialysis schedules on left ventricular hypertrophy. Although if the left ventricular hypertrophy is very high, there may still be a benefit for more intensive dialysis schedules. And there may be possible accelerated loss of residual urea clearance if we dialyze patients more than 24 hours per week. This was some data from the FHN trial. And it's also susceptible to loss with very aggressive volume removal strategies. And it may be worthwhile, we don't know. But with very aggressive volume removal strategies or with more than 24 hours weekly dialysis, the kidneys tend to shut down within 3 to 6 months. And so this at least we have to be cognizant of this fact. Now, weekly fluid ultrafiltration is one way to get an idea of a patient's weekly fluid intake. So simply weekly fluid intake is weekly urine volume. Weekly fluid intake minus weekly urine volume is how much you have to remove by ultrafiltration. And then it's very simple. I mean, the ultrafiltration rate is going to be the weekly fluid removed by the weekly dialysis time. If the weekly fluid removal needs are high, you may have problems, especially during the long weekend interval. An advantage of such patients may benefit from an alternate QOD schedule or an addition of a Saturday dialysis to limit ultrafiltration rate below 13 or 800 mils per hour, or less than 10, some people say now. Here's some early studies showing that if the session ultrafiltration, this is 3 times a week dialysis. This is work by Flythe looking at the hemo study. And you all know this data that if the ultrafiltration rate is above 13, that there was a 50% increase in mortality rate. And similar data by Movilli in Europe, who just divided the average ultrafiltration rate. And if it was above 12, the mortality rate was, the survival curve was much less than if the ultrafiltration rate was below 12. I think that maybe this is a detail, but the problem when you look at ultrafiltration rates by kilo is that you may be too severely restricting small patients, and you may not be sufficiently restricting large patients. For example, if you have a patient with maybe who weighs 150 kilos, and we have those in the US. An ultrafiltration rate target of 10 will be 1.5 liters per hour, which I think is ridiculously high. Whereas in a 50-kilo patient, if you're aiming for a target of 10, then you can't go above 500. And so we did some physiological analysis that perhaps the body size should be a little bit less severe and maybe adjusted for body surface area. This just shows the increased mortality on a Monday or Tuesday treatment after the long weekend interval. And we don't know whether this is due to more rapid ultrafiltration, higher electrolytes, arrhythmia. But again, this is one limitation of a 3 times a week schedule, as you all know, and why home dialysis with every other day dialysis would be technically useful. So why is it important to know if there's LVH? Well, again, part of the problem is that many people who have put people on a more frequent dialysis schedule have done it with the goal of lowering left ventricular mass. And that's because left ventricular mass is a very strong prognostic indicator of survival in dialysis patients. And in fact, most studies have shown that if you do frequent dialysis more often than 3 times a week, left ventricular mass index will drop. One problem is that some of the most impressive studies have started out with patients with very, very high left ventricular mass index, and why they had this sometimes well above 150 to 200. So the question is, why do they have such a large ventricular mass index to begin with? When we did the FHN trial, we were surprised that only about, where we measured left ventricular mass index by a sensitive method, MRI, we were surprised that only about 30 to 40% of patients had LVH. And it's the old thing that if something isn't broken, you can't fix it. And one thing that has been underreported is that in the control group in the FHN trial, left ventricular mass index did not seem to increase over 2 years of 3 times a week dialysis, which suggests that perhaps the 3 times a week schedule is not that bad. It may not improve left ventricular hypertrophy, but it may not make it any worse. And these are our data showing the effect of frequent dialysis on left ventricular mass index based upon the baseline left ventricular mass index. And so this is a treatment effect. The red line is 0 going to 20%, 40%, 60%. And as you can see, is if the baseline left ventricular mass index was less than 100, there was no effect of frequent dialysis. And then as the baseline went to 150, 200 grams, you started to get a huge benefit from 6 times a week. Actually, it would wind up being more like 5 times a week versus 3 times a week dialysis. So when you see a patient and you put them on dialysis, you want to talk about their hemodialysis schedule, some type of either echocardiogram or even better, an MRI to look at their left ventricular mass index. It might be very useful. And if it's very high, then you might plan for home dialysis, every other day dialysis, or some type of daily dialysis schedule. Another issue is urine volume. When we looked at our patients in the FHN trial, and this is the effect here of frequent dialysis on left ventricular mass index. And in those patients where urine volume was less than 100 mils a day, there was about 20 gram lowering effect size of frequent dialysis. Once the urine volume was high, the effect size was much less. This was not quite significant, but the trend was there. It was also there in the nocturnal study where we divided patients who had more urine output, who had greater or less than 500 mils per day. And again, the effect size of more frequent dialysis versus 3 times a week dialysis was higher in those patients who had less residual kidney function. So certainly if a patient has residual kidney function, does not have left ventricular hypertrophy, if you are planning a more aggressive than 3 times a week schedule for such a patient, you have to think of why you're doing that. There may be other reasons and other benefits, of course. Is home dialysis available? We know that patients dialyzed at home do better regardless of dose. And the question is this a confounding effect? Are these just better patients, who are more concerned about their health, who have better social support structures? And these things can't be measured no matter how many comorbid factors you identify to. Or is there something else? Less interruption of daily routine, no transportation hassles, less exposure to unskilled stickers in the unit, which sometimes you may have 5 patients who are accessing the access in a unit. Maybe 5 of 6 are very good, maybe 1 is not so good, and possibly less exposure to infectious agents such as flu, etc. And of course, we know that home dialysis is easier for non-standard schedules, every other day, 4 per week, 5 per week, short daily. It's very difficult to implement a 5 per week schedule or even an alternate day schedule in center, as you all know. Is in-center nocturnal dialysis available? This is usually done overnight, and usually the treatments last for 6-8 hours longer. So the weekly dialysis time is doubled. Non-randomized data, better outcome, maybe better in terms of patient rehabilitation. They have more time during the day to work, to do anything. And even though in FHN there was an accelerated loss in patients in the nocturnal arm, these were patients dialyzed for 6 to 8 hours a day, 6 times a week. But if we go back to a total weekly dialysis time less than 24 hours, and there were a number of those in the FHN trial, there did not seem to be an adverse effect on residual urea clearance. This is just some survival from J.R. Laxon's group when he was at Fresenius, looking at their in-center nocturnal. It's not a randomized study. The top line is the in-center nocturnal hemodialysis. The solid line is conventional 3 times a week dialysis. And they had you can see there's a good separation in terms of survival. When we talked about ultrafiltration rate, we wanted to keep it below 13 or even better below 10 mils per kilo per hour. In the conventional group, the ultrafiltration rate was 12. When they put them on nocturnal, it went down. You double the time, they didn't take in much more fluid, so the average ultrafiltration rate was all the way down to 6. So this may be one huge benefit of nocturnal in-center dialysis. Is HDF available? So here we have initially there were 3 studies, the Turkish study, the contrast study, and the ESHAL study that looked at this. They were randomized trials. And the two of the studies showed no benefit statistically. And there was a study from Spain that showed a very marked benefit called the ESHAL trial. There was a meta-analysis done of these studies. And
3 more minutes, 3 to 5 more minutes.
3 minutes? Okay. My study shows 20 minutes, 21 minutes that I've been talking. But so online hemodiafiltration had no advantage, but there was better survival in patients with large convective volumes. And the interesting thing about this is maybe the benefit in the Spanish study was not due to removal of middle molecules. If you look at the contrast study where they compared HDF to low flux dialysis, there was no difference in survival, yet there was a huge difference in beta-2 microglobulin. It started out about 30, it went up to about 35 in the patients dialyzed with low flux membranes, and went down to about 25 in the patients on hemodiafiltration, no difference in survival. In the Spanish study where they found a 30% difference in survival, there was absolutely no difference in the beta-2 microglobulin levels. So the conventional wisdom is this is due to removal of middle molecules, but maybe there's something else. And I speculated that this may be due to something about cooling. When you give high volume replacement fluid, you may lower the extracorporeal temperature. So here's one study suggesting that increased lean tissue mass, this needs to be confirmed. So in the US, we don't care about these. Which outcomes are important to patients and caregivers? These are preliminary outcome domains. Health-related quality of life now in the US is something that we are looking at. There's a physical composite score. which is very low in ESRD compared to many other diseases. There's a mental composite score that also is severely impacted in ESRD compared to other diseases. These are not improving over time, and both of these scores are related to mortality. So this is something we need to look at. There was a KDIGO controversies conference with a focus on symptoms, and very interesting study by Chris McIntyre. They're looking at monitoring PROs on a continuous basis with a simple questionnaire, just asking 8 questions, but doing this almost every day through a web-based interface. And you can already see that there's a difference in energy score between dialysis days and non-dialysis days. And what's interesting is you can look at trends over time. In this case, these are all these patient-reported outcome score, and when they start daily dialysis, there's a marked improvement. Post-dialysis recovery time is something that we need to look at. It's very important to the patients and cognitive function and depression. So in summary, adequacy in dialysis is multifactorial. I'm going to talk tomorrow about the actual KTV targets, that they should be higher in women and small patients. For patients with higher with some KRU and residual kidney function, incremental dialysis may be okay. If left ventricular hypertrophy is not present, you should not do more frequent dialysis for this purpose. In my opinion, benefits of HDF remain somewhat unproven, at least not by removal of middle molecules. And more emphasis needs to be placed on tracking patient-reported outcomes, quality of life through these physical composite score, mental composite score, and post-dialysis recovery times. Thank you very much.
Thank you very much, Dr. Dugardis. I think we'll go for audience questions. I think there are more than one question asking about residual kidney function. So the first one is asking about how to preserve the residual kidney function when you start somebody on dialysis for the first time. And the other question is for patients with residual kidney function, would you like to start like thrice weekly treatment versus twice weekly treatment? So what's the recommendation in that matter?
So I think this is very controversial, and I had some bonus slides about this because I anticipated some of this. This was a study done by Dr. Kalantar-Zeta in the US, and he was looking at mortality of 3 times a week versus twice a week dialysis. And he found that you could do incremental dialysis as long as the urine volume was more than 600 or the residual urine clearance was more than 3. Once you started to, there was no difference in mortality between the two. At urine, once the urine volume was greater than 600 or KRU was greater than 3. Once less than 3. Once the KRU was less than 3 or the urine volume was less than 600, the mortality rate increased by 50% by doing incremental dialysis. Now, this report was not confirmed. There was a study out of China called KDOPS, and what they found was twice a week versus 3 times a week dialysis, even in patients making less than 1 cup per day, and they found no difference in survival. And there was a Korean study that found also very little impact of residual kidney function. So I think this is somewhat controversial. I think in KDOKI, we recommended that once the residual urea clearance was greater than 2, you should not do incremental dialysis, but do at least 3 times a week dialysis. But there is some discrepancy between the US results and Korean and China results in this area.
The other question is about loop diuretics, using loop diuretics in those who are on dialysis. Is there any rule to continue on loop diuretics for those who are hypertensive and start dialysis? I
believe it's very important to use loop diuretics as long as you can to maintain residual kidney function. Obviously, you're reducing the amount of ultrafiltration you need. There's a very small studies suggesting that you may have better patient survival with loop diuretic use. In the United States, it's not practiced nearly as much as it is in Europe. So for whatever reason, and I personally believe, I think it's a very, very good strategy of maintaining a residual kidney function. Whether twice a week dialysis or incremental dialysis maintains residual kidney function, again, somewhat controversial, but there's some evidence that if you do start dialysis off at twice a week, the patients do maintain residual kidney function better. I think the scary part is sometimes with these infrequent dialysis schedules, then you have to do a very high ultrafiltration rate. So we still don't know whether, but again, I think that if you're dialyzing patients incrementally, you can minimize the ultrafiltration rate by giving loop diuretics and also by lowering the sodium intake.
Thank you very much. I think we reach our time. So that was very, very nice presentation. Thank you, Dr. John. Got this.
Pleasure.
Dr. Khalid Hassan.
Yes, thank you very much. So can Dr. Siddharth share your slide? Yes. So Professor Abdullah Al-Harbish, just introduce yourself and the speaker.
Assalamu alaikum.
Abdullah Huish.
That's okay. Assalamu alaikum and good evening, ladies and gentlemen. I am Professor Abdullah Al-Huish. I'm a professor in internal medicine and nephrology from Imam Abdurrahman bin Faisal University, Al-Khubar. I was honored to present the second speaker, Dr. CRRT Kumar City. He's a consultant pediatric nephrologist at Medanta, the Medicity of Korean in India. Dr. CRRT, he has earned his nephrology fellowship from India Society of Nephrology in 2010, and he's a well-known figure in international figure in pediatric nephrology. He's elegantly presented yesterday the acute kidney injury, epidemiology, and outcome, and today he will talk about the role of PD in acute kidney injury, or I'm gonna rephrase the topic is real supportive therapy in acute kidney injury. Dr. CRRT, the mic is yours and most welcome.
Thank you for the introduction. And first of all, it's an honor to speak after Dr. Dogirdas and before Dr. Ronco. It's a real honor to be here. And I would like to thank Saudi Society of Nephrology and Dr. Khalid, who is a very good friend and a collaborator, to invite me here. Over the next few minutes, I'll be talking about peritoneal dialysis, the role and where we stand in the role of peritoneal dialysis in pediatric AKI, especially in South Asia. Now, this was a survey by Dr. Bunchman way back in 2000, where he surveyed the centers in North America. And they asked which is the most common dialytic modality they used for AKI in children. And Dr. Bunchman showed that over the last few decades, now CRRT is more commonly used in sick children as compared to PD, especially in United States. But they still showed that in children who were small, who were less than 2 years or less than 6 years, PD was still commonly done in smaller infants, even in the US. So this was a survey from America. Now, this was the first survey from our country, and this was a survey from St. John's Medical College, where they showed, again, they asked, which is the most common modality for dialysis in children. And again, they showed that in India, PD was the most commonly used modality in children with AKI, especially in young children. And as the children grow older, as we are aware that vascular access is easier to perform in older children, so hemodialysis was commonly done in children more than 12 years with acute kidney injury. And what determined the modality was patient size, hemodynamic status, the duration of AKI, but it is important to note that even the socioeconomic status, the personal choice of the physician also played a role in determining what modality to use. So the surveys were mixed. There was a survey from a developing country, a survey from America. So me with our collaborators from all across the world, Rupesh, Tim, David, Akash, we did a survey all across the world. We distributed a survey through PDNF listserv and also personal communication to many collaborators all over the world. There were almost 250 responses. And as you can see, these orange dots, these were all pediatric nephrologists who responded from all over the world. And in fact, from the US, we had 55 responses from out of the 250 responses. Now you can see some green dots here. Now these green dots were actually adult nephrologists who responded to us and who told us that they were the primary caregivers for children with pediatric AKI. So it's important to realize that not every child with AKI who is sick gets a pediatric nephrology care. So even there are adult nephrologists who are taking care of these children, especially in the developing world. So when we asked them, who manages a sick child? So there were a fraction of children being managed in the developing world by adult nephrologists, by general pediatricians, because pediatric nephrology care is not everywhere in the country and in Asia. So in fact, most parts, pediatricians and adult nephrologists were the primary caregivers. And when we asked them, are you able to do pediatric CRRT in a child less than 10 kg? So there were only 2 centers. There were 4 centers in our country who responded that they do pediatric CRRT. And there were only 2 centers who told us that they could do CRRT in a child less than 10 kg. So not many centers do CRRT in very small kids. Now, who pays the cost for RRT in sick kids? So especially in the developing world, we found in this survey that not everyone is insured. And once a patient gets sick, it's an out-of-pocket expense for the whole family, and it drains their money. Not everyone is insured. When we ask them, which is the modality of choice for unstable child with AKI in your country? So we found in the developing world, PD was the most commonly used modality, while in the developed world, CRRT was the most commonly used modality in sick children. So PD was still the most commonly used modality in the developing countries. Now, what was the choice of modality in a sick child who is older? Again, PD was commonly used in the developing world. Now, what was the choice of modality all across the world in infants with AKI? And again, we found that PD was most commonly done in infants. Whether it was developing world or the developed world, PD was still commonly used, more in the developing world as compared to the developed world. Now, what about newborns? What about infants and newborns with AKI? So over the last few years, we even discussed this with neonatologists. So we collaborated with all the neonatologists in the country. We collaborated with the National Neonatology Forum of India, and we had collaborators from different parts of our country. We have Rajiv here from East India, Arpana from South India, and these are the neonatologists. So we sent a survey to the neonatologists of the country asking what is the perception of peritoneal dialysis in newborns. And out of these 800 correspondents, almost 250 responded to us. And most of them were neonatologists and primary pediatricians who take care of newborns in our country. And we found that they do, what are the indications of dialysis in newborns? And all of them felt that oliguria, dyselectrolytemia, metabolic acidosis, fluid overload, these were the main indications for dialysis in a newborn or a neonate. Oliguria, dyselectrolytemia, persistent metabolic acidosis, fluid overload, and urea creatinine was just a number, and it was not an indication for dialysis. When we asked them, which modality do you use in our country, in India, again, PD was the most commonly used modality, and only a fraction of them, around 5% of neonatologists would have access to CRRT in newborns. Hence, PD is a common modality in children who are having severe pediatric AKI in the developing world. And I'm happy to announce, and I'm happy to share with you that over the last 1 year, we are trying to make a database of severe AKI in SARC nations. Me with all of my friends from SARC nations, and I'm happy to share with you that all of those friends from SARC nations are right now, they're attending this webinar. So all the flags, you can see all countries are right now attending this webinar. and they are part of our study. So the inclusion criteria is a child with severe acute kidney injury requiring dialysis. There is not even a single study talking about what is the cause of AKI in a child who requires dialysis. So we are trying to establish and identify the epidemiology and risk factors, and I'm sure this will help us to find and do some targeted approaches to prevent AKI in these children. And we are thankful to IPNA for supporting this cause. I'll just show you some results which we are able to obtain over the last 1 year. And remember that these are sick children requiring dialysis. And till now, the maximum enrollments which we have got are from Myanmar and Pakistan. Our friends from Myanmar and Pakistan and Bangladesh are right now listening to this talk. And most of the enrollments are from there. This is from Pune, D.Y. Patil. And as you can see, a lot of children are on dialysis with AKI. Now, what is the most common etiology which requires dialysis in SAARC nations? And the most common 3 causes appear to be, till now, it's just 1 year of data collection, nephrotoxic drugs, hemolytic uremic syndrome, and acute cortical necrosis. So these appear to be the most common causes of AKI requiring dialysis. And which is the most common modality used in the SAARC nations? Again, peritoneal dialysis is the most common modality used. Now, what about COVID and peritoneal dialysis? So as members of the PCRRT Iconic Foundation, Rupesh, Tim, and me, we made a PCRRT consensus on how to manage a sick child with COVID, and if he requires dialysis, which dialysis should be performed. Now, this algorithm is there in this paper in Frontiers. And what we said was that all the units who manage sick children should have a disaster plan in process. They should have a disaster plan, how to manage that child if there's a disaster. And now we did prescribe a high dose CRRT as the modality of choice for these children, but we do endorse that if you have a sick child, you may use a SLED with convection or a peritoneal dialysis in patients if you do not have access to CRRT or a high dose CRRT in these children. So PD is still a good modality even for sick children. I'm aware of an editorial from South Africa by Dr. Mignon published in Lancet just now, where they showed a very good survival of a child with COVID and MISC who required peritoneal dialysis, and they could save the child by peritoneal dialysis. So coming to just a representative case, a 3-day-old baby who got hypoxic ischemic encephalopathy, and this baby has a high urea creatinine, has a creatinine of 4 milligrams per deciliter. This baby has refractory hyperkalemia, refractory metabolic acidosis. So what would be the modality of choice in a sick newborn like this? Now, what determines the choice of modality? The patient size, the hemodynamic stability, and the expertise. So if you have a smaller child, most of the centers, if you have a newborn or an infant with hyponatremia, will be doing PD first. If he's sick, we'll do PD or CRRT. But it also depends on the institutional expertise. We do these workshops every year, and we always say that it's not like CRRT is the best for a sick child. It's you do what you are good at. If you're good at PD, PD can save lives. PD can save life even at war front in Afghanistan. You don't need to be a CRRT expert to perform a dialysis in those situations. PD is excellent because PD is not so complex like CRRT. PD is cheap. It's not so costly. It does not require a vascular access, does not require any anticoagulation. You can do it even in hemodynamic unstable children. Now, all we need for PD as compared to hemodialysis is an intact peritoneum. It's cheap, minimum infrastructure is required. So all we need is an intact peritoneum. It's a very good modality, as I showed in infants who are hemodynamically unstable. It's more physiological, a more gradual way of removing solutes, though less efficient as compared to hemodialysis, where you have rapid shifts in the fluids and osmolalities. So on the other hand, hemodialysis is a good modality for an older child with a prolonged AKI. Now, the common placement sites which we use for PD are just below the umbilicus, or usually the left side, just lateral to the abdominal muscles on the left side. So usually we avoid the right side. Now, what are the catheters which are available? Now, age old in 1926, this was a stainless steel catheter which was available for PD in adults. But now things have changed and newer catheters are available. The options which we have for catheters are a rigid, stiff trocar catheter, a rigid catheter. We can use a double cuff tank-off catheter, which is usually used for chronic peritoneal dialysis. A Cook's catheter sometimes, if you don't have any catheter, a Cook's catheter, even a femoral catheter, and the most commonly used, a single cuff tank-off with a peel-away sheath. Now, this is the most commonly found catheter in the developing world, a rigid, stiff catheter with a trocar. So what is there? It's just a stiff catheter with trocar in situ. Trocar is withdrawn, and you can do dialysis through the end and the side holes. So we have a bead in this stiff catheter, which is placed to secure the catheter, and the peritoneal dialysis fluid runs through the end and the side holes, and we can perform dialysis. It's very cheap, just $5. It's easy to insert. We teach this to our residents. There's no specialized expertise required, no nursing care required, minimal nursing care required, and easily available. However, when you use a stiff catheter, there's a risk of traumatic insertion. You may perforate the viscera, especially in a very sick preterm who is extremely low birth weight. These catheters require reinsertion sometimes. They may have malfunctions. We need to have a patient who is bedridden, he needs to be bedridden. He cannot move around when you are doing a stiff PD. There's a risk of peritonitis. There's a risk of leakage of the PD fluid if you use a stiff catheter. So we teach this every year and every month to our residents and the residents all across the country, that remember that stiff catheter is just a 48 to 72-hour affair. We should not keep a stiff catheter in for long. So remember, there's a significant risk of leakage, malfunction, peritonitis, particularly if you're prolonged usage of this catheter. So now less and less centers across the country use stiff catheters, as we are now teaching them more about using tank-off catheters. Now, there's a double cuff tank-off catheter, which all the audience is aware about. There's a proximal cuff, which is implanted in the preperitoneal space, and there's a distal cuff in the subcutaneous tissue. However, as pediatric nephrologists, we usually do not place the double cuff catheter ourselves, because we need to go to the OT to insert the double cuff tank-off catheter. It requires a bit more expertise and dissection to insert a double cuff tank-off catheter. So there is a subcutaneous cuff and a peritoneal cuff in a double cuff tank-off catheter. However, now all of us have a single cuff tank-off catheter, which can be used in children with the AKI. It just has a single subcutaneous Dacron cuff, which can be felt. And this cuff is of advantage because it makes a bacteria tight seal and it prevents the bacterial transmigration. And we can do it bedside. Now, what are the advantages of a soft tank-off catheter is that there is decreased incidence of infections. We have used these catheters even for 6 months to 1 year in a child who is sick. So in fact, we need to anticipate that. If you have a child who is already anuric for 2 weeks, you know that he requires a prolonged dialysis. Why to put a stiff catheter in? Go and put a bedside soft tank-off catheter. There are no reinsertions required. You can use it for months, better compliance, and you can use it for a longer period. Now, I'll just show you a short video which I made when I was a fellow of how to insert a bedside tank-off catheter. So as I told, it's very easy to put a tank-off catheter. So all we need is we check the patient's vitals beforehand. We catheterize the child beforehand, sedate the child beforehand. Now, before we do the dialysis, we need to do a skin preparation. This was a child who required multiple PD insertions, was anuric for long, had received multiple stiff catheters, and we finally inserted a soft Tenkov catheter. So we prepare the skin, and now we create the artificial ascites. So just like a normal PD, we create artificial ascites using a thick bore IV cannula. We create artificial ascites. So here we are creating artificial ascites. Now over the IV cannula, using the same Seldinger's technique, we advance the guide wire over this cannula. So it's using the same Seldinger's technique. We advance the guide wire over it. And now over the guide wire, now this cannula goes out. Now over the guide wire, we will insert the sheath. So we'll insert the dilator with a sheath. So here is the guide wire only in the child's tummy here. And over the guide wire, we will insert the dilator with the peel away sheath. Okay, so now we are inserting the dilator with the peel away sheath over the guide wire. Now, once this completely goes inside, so this has to completely go inside. Now over this, we remove the dilator now. And over this, now we will put the Tenkov catheter with a single cuff. By now, you will find that there will be some PD fluid coming out. Now, once the catheter is inside, we peel away the sheath. So we peel away, we break open the sheath and we peel away the sheath once the catheter is inside. And slowly I'll just fast forward that and we will be able to peel away the sheath completely. And now only catheter is here and the whole sheath has been peeled off. And now is the time to create a subcutaneous tunnel for the subcutaneous cuff. So we create a subcutaneous tunnel and you can use a mosquito's forceps for that. And you can easily create a subcutaneous tunnel. Remember that there should be no kink at this point when you insert this catheter. Once you have inserted the catheter, and here is the catheter, you can see that. Remember, we are creating a Y set here so that you don't need to spike the bottles again and again. More spiking of bottles we do, more is the risk of peritonitis. And now you can do a test cycle. Remember, we don't need to put any suture at the exit side. So the suture is only here. So this is a very safe way of putting a soft Tenkov catheter in children with AKI. Remember to use Y transfer sets because it has been demonstrated in multiple trials that Y transfer sets reduce the risk of peritonitis in these patients. And the beauty of the catheter is that we can use an automated PD machine with it. It's a one-time connection. So we can do the whole AKI for AKI dialysis in this child for the next 2 to 3 days by just a single time connection. So there's less risk of infection. And of course, as all of us are aware that this home choice machine would tell you every ml of water which has gone inside and the ultrafiltrate. It warms the fluid to the body temperature. So there's less risk of hypothermia also as compared to the routine peritoneal dialysis, which is done in AKI. Now, over the last few years, there has been advancements in how can we increase the efficiency of peritoneal dialysis. So can we increase the efficiency of peritoneal dialysis? Now, most of these studies are on chronic peritoneal dialysis, but there are reports on using this variety of the modification of PD in children with AKI. And the modifications include a continuous equilibration PD, where you have a fill volume and you do dwell every 4 to 6 hours by a cycler or manually. The benefit of a continuous equilibration PD is that you can remove higher middle molecules as compared to a standard PD. We can do a high volume PD with a cycler, and you can do multiple exchanges, almost 18 to 24 in a day. The advantage of a high volume PD would be you can have a faster recovery of the renal function because of less episodes of hypotension in these patients. So it's postulated that it may help in a faster recovery of renal function. Most of us do a tidal PD using a cycler. So over a reservoir, we do tidal cycles using a cycler, and it's thought to have a higher, smaller, and a middle molecule clearance as compared to a standard PD. And there are multiple reports, especially from Cape Town, South Africa, of continuous flow PD, which is very interesting, where what we do is you have two peritoneal catheters, one for the inflow, one for the outflow, and you have a fixed dialysate flow rate of 100 to 300 ml per minute. So it is thought to be very interesting and efficient by having a higher small and a middle molecule clearance and higher ultrafiltration rates. So we are all very excited about continuous flow PD, and we are looking forward to more and more reports from different centers on continuous flow PD in children with AKI. Now, PD is cheap as compared to hemodialysis. So if you compare, say, a stiff trocar catheter, it costs around $5. A Tenkov is costlier, it costs around $100. A peel-away sheath, in fact, costs more. You need to have, it's cost another $100 if you want a peel-away sheath along with a Tenkov catheter and you want to insert it bedside. Cycler costs a lot more. However, these companies are able to give it free of cost to us if we use their fluid. So the cycler usually comes free. On the other hand, we are all aware hemodialysis and CRRT is a lot costly as compared to PD. So just an algorithm of what we commonly use PD for in children. So in a child who is a neonate or an infant, in smaller children, we do use PD. And even in children who are older, when you do not have access for peritoneal dialysis. Hemodialysis is, of course, a very good modality for hyperkalemia, refractory acidosis in older children. And CRRT is, of course, an excellent modality for children who are on multiple inotropes, sepsis AKI, who have overwhelming sepsis. CRRT is a very good modality. So coming back to the child, for this child, of course, PD is a very good modality. And here you can see a PD catheter being put in this child. So to summarize, PD appears to be a very safe, physiological, and even efficient way of dialyzing children in developed and even in developing world. There are very specific situations where only PD works in less resource areas, infants. In my center, we do a lot of cardiopulmonary bypass, and our cardiac surgeon, in fact, puts a PD in. If he finds you have a patient who is requiring a prolonged surgery, he will himself put a PD catheter in and manage the fluid thereafter after the surgery. Hypernatremia is a very important indication in infants when we do PD. You cannot manage a child with a sodium of 170 with hemodialysis. Very uremic patients. PD is such a physiological way, and we have used PD very commonly in children who come to us with uremia, advanced uremia, a urea of 400 and a creatinine of 20. And PD is a physiological way of removing solutes in those patients. Of course, we need to devise ways to improve more efficiency of PD, especially in the AKI setting. Now, over the last few minutes, whatever I spoke of, the protocols and the guidelines, I would refer all the residents to this AJKD core curriculum, which we wrote way back in 2014. It's available free of cost. It's freely downloadable from the AJKD website. And we do the PD workshops and the RRT workshops in India since almost last 10 years. This year, we could not do our RRT and the critical care pediatric nephrology course due to COVID, as everyone is aware. And I invite all of you to India next year when we perform our next AKI training course. We have stations on PD, CRRT, SLED, which we do almost every year. And most probably the meeting will be in May next year. And I would refer all of you, especially the residents, to this textbook. There was no handbook of how to perform a CRRT in a child. There was no, when I was a fellow, there was no handbook of how to perform SLED in a child, PD in a child. So we four, especially our mentor, Dr. Bunchman, Professor Mignon, and my dear friend, my brother, Rupesh, we have tried to make a consensus, a handbook of critical care pediatric nephrology. So I feel this will be a very good resource for all of you. And this was my last slide. And I thank Dr. Khalid and the SSN for inviting me here. Thank you.
Thanks, Dr. Seda, for an excellent overview about BD and acute kidney injury in the pediatric. My question, there is actually no single doubt that PD is very effective in acute kidney injury because it is more hemodynamic stable, the patient, no need for anticoagulation, good preservation of residual renal function, a lot of advantage. From your view, why the BD is not spreading in the other worldwide? Why it is now most of the people are talking about CRRT, and the mortality is the same for CRRT, for SCAF, BD. Maybe BD also better, a little bit better than the other modality. From your view, what is the barrier of unspreading?
So there's not even a single bigger trial comparing PD to CRRT in children, which says CRRT is better. So you're right that, but of course there are some special situations where CRRT may be better, especially in a child with, say, liver failure, a child with septic AKI, where, or even a child with hyperammonemia, where you may have a better solute clearance with CRRT. So of course, but in rest of the other clinical situations, PD is as good as CRRT. However, there are specific situations where PD is better, like I showed, and there are situations where CRRT is better. For example, hyperammonemia, a septic AKI, liver failure is a very important indication for CRRT in children.
What is the target KT over B in acute kidney injury?
So again, there are not many studies on, especially looking at KT over V in AKI in children. So all the studies are being extrapolated from chronic dialysis. So I would not like to comment on because we do not concentrate on KT by V when we are trying to manage a child with AKI. So because everything is extrapolated from chronic. So we need to have, like I mentioned, we need to have more studies looking at efficiency, how we can increase the KT by V and maybe correlate it with outcomes.
We have a question from Faisal Rahman. After, he's saying, after peritonitis, did you remove the BD catheter, or how you manage the patient with peritonitis and acute kidney injury?
Of course. So for a stiff catheter, if you get peritonitis, the answer is remove the catheter. So for a stiff catheter, the answer is remove the catheter. But if you have a soft Tenkoff in place, we use the ISPD guidelines for managing peritonitis. So the standard ISPD guidelines for managing peritonitis work, even in a soft Tenkoff catheter with peritonitis with AKI.
We have other question from Muhammad Yasiri. That does a patient with a permanent suprapubic urinary catheter is a good candidate for PD?
So yes, of course, we can do PD even in those children, and we can even do a CAPD, a continuous, a child with ESRD with complex malformations. Even those children are a good candidates for CAPD. So we have done, and we have even seen children from even Middle East and our country who have done reasonably well with complex genital malformations and a PD.
Yeah, because of the time limit, I would like to thank you very much for elegant presentation. And now the time is over, and we go for the second speaker. Thanks.
Thank you.
Okay, so thank you very much. So the next talk is supposed to be for Professor Claudio Ronco, and I hope he will join us now. He still didn't join until now. I think within a minute he will be joining. Just a quick announcement. At 8 o'clock in Riyadh time, so after half an hour from now, Hall B will be open, and it's already opened now, but they will start exactly by 8 o'clock the talk by Sandeep Mitra, Professor Sandeep Mitra, from the Industrial Symposia sponsored by SPIMACO. So exactly by 8 o'clock, there will be a parallel session in Hall A and in Hall P, and both of them as Industrial Symposia. So just we'll give probably a break for 5 minutes, 5-minute break, waiting for Professor Claudio Ronco to join us. So until Professor Ronco to get in, so I would like to also let our valuable audience that enjoy getting in to the website of the conference, and you can go to the lobby where there is you can do networkings with your colleagues for any clinical questions, as well as conducting a research or others. Also, exhibition hall, where is our sponsoring company are there. You can see them, you can communicate with them by chat, by phone, by everything. So enjoy the real virtual conference, exactly the entrance like hotel entrance with the imaginations of the Riyadh view. And the other thing also, I have sent by chat as well. It is available in the website for social networking. There is a hashtag by the conference. Please feel free to write your experience in that hashtag about this big conference. البث السلام عليكم ورحمة الله وبركاته. البث موجود ولكن احنا متوقفين few minutes ننتظر البروفيسور كلاوديو رونكو، فنتوقع انه تقريبا حوالي 5 دقائق من الان انه ان شاء الله حيدخل، علما انه القاعة الثانية هول بي موجود البروفيسور سانديب مترا already he's locked in وينتظر الساعة 8 عشان يبدأ المحاضرة حقته بإذن الله. هول بي. هناك أسئلة كثيرة. There is many questions actually from the audience. They asking about the CME hours. So anyone who registered in the website of the conference and also he registered his number of the Saudi Council for Health Specialty, he will earn 18 hours once he attended more than 50% of the conference lectures. Those who attended part of it in YouTube should be fine once at least 50% he attended in the website, and it will be entered by our office electronically using your Saudi Council number. So if you want to, I see your some of the questions. If you want to attend Hall P through the website of the conference, so you need to log out from here and you'll find a link to Hall P when you choose the lecture of Professor Sandeep Mitra. Also, in the YouTube, there is a special link for the YouTube link for Hall P. So you can go to the link of the whole beam. And actually it's the same link of the yesterday was used for the YouTube. Okay, so Professor Ronco, he answered us now, and he have real serious family issue, and he apologized for today. We'll try to arrange his talk tomorrow, inshallah, and they will let you and update you. So this room will conclude now. This room for any for the talk, and you can move to the hall B to attend the talk of Professor Sandeep Mitra about updating treating anemia in CKD and hemodialysis patients. So see you tomorrow in hall A, and we'll update you about the 2 lectures of Professor Ronco. Hopefully we can arrange it tomorrow. Thank you very much, and see you tomorrow. And also, if who's interested, we'll see him in hall B. Thank you.